aneurysms. And before I start my lecture, I'd like to express my grateful thanks to Dr. Priyadarshi Dikshit. He is the postdoctoral fellow in our department. He has made some outstanding schematic illustrations for this presentation. So let's talk about the anatomical principles which govern surgery for paraclinoid segment aneurysms. We are basically interested in three segments of the internal carotid artery. The cavernous segment, which starts from its vertical portion, then becomes the horizontal portion, till it becomes the clinoidal segment, which is enclosed within the carotid collar, and then it becomes the supraclinoid segment till the posterior communicating artery. And just after it comes out to the carotid collar, we have the ophthalmic artery, which goes along with the optic nerve into the orbit. Now, the C5 segment or the clinoidal segment is a potential extradural space which is only visible when the clinoid is drilled. And this is covered by the carotid collar. The proximal part of the carotid collar is formed by the proximal dural ring, and the distal part is formed by the distal dural ring. And these are the three segments, C4, C5, and C6 segments of the ICA that we are actually interested in. Now, let's look at the formation of the proximal and the distal dural ring. So this is the cavernous sinus. These are the third, fourth, V1, V2, all these nerves, and this is the superior orbital fissure here. And this is the sagittal section. So what you see is that the proximal dural ring is the condensation of the fascia of the cavernous sinus, distal part of the cavernous sinus. It goes below the anterior clinoid process and goes to the planum sphenoidale here. The distal dural ring is the distal part of the clinoidal segment, and then it goes on the superior surface of the anterior clinoid process, goes on the planum sphenoidale, and therefore, when we are cutting the dura over or the fascia over the anterior clinoid process, then this is the part which is attached to the distal dural ring here. Now, a few principles about clinoidectomy. So this is the greater ring of the sphenoid. So when we are doing a frontotemporal craniotomy or a pterional craniotomy, though this is the clinoid, and we already drill up to the superior orbital fissure here. So this greater wing of this and lesser wing of the sphenoid, we drill up to the superior orbital fissure. Then the clinoid has two more segments. One is the anterior strut, which connects it to the planum sphenoidale, and there is a posterior strut which connects it down below. Now, when we have drilled the optic nerve foramen, we have disconnected the anterior clinoid from the anterior strut here. And when we have disconnected the posterior strut by coring out the anterior clinoid process from within, then we have disconnected the posterior strut. And that is when the entire clinoid becomes mobile, and that you can remove it with dissectors. The other important thing is, so this is the posterior strut, this is the wing of the sphenoid, and this is the anterior strut, which is actually overhanging the optic foramen. So always drill out the optic foramen, greater wing of sphenoid up to the superior orbital fissure, and then coring out the anterior clinoid from inside, drills the posterior strut. The ICA comes out like this and then becomes supraclinoid here. And therefore, when you're drilling and coring it out from inside, just below your coring segment, the ICA is not actually present. So that is why it is reasonably safe to do. So again, just to re-emphasize, if this is the optic nerve and optic foramen, this is the part of the planum sphenoidale that when you drill, you remove the anterior strut, greater wing of sphenoid when you drill, then and the lesser wing of sphenoid, then you remove this part of the anterior clinoid. And then when you core it out from inside, you actually are drilling out the posterior strut of the sphenoid. And therefore, what you expose is the C5 segment or the clinoidal segment, which is present between the proximal dural ring, which is the condensation of the cavernous sinus, and the distal dural ring, after which the ICA becomes supraclinoid and the ophthalmic artery is just distal to the distal dural ring. Now, what are the types of aneurysms of this location? So one is a carotid ophthalmic aneurysm, which is just below the optic nerve here. The second, and it presses on the optic nerve and causes unilateral blindness with primary optic atrophy. The second is a dorsal aneurysm, and this is like a punched out button on the ICA, dorsal surface of the ICA. And when you put a clip on this, then there is this danger of the entire button simply being removed and the entire ICA bleeding into the subarachnoid space. So this is a very, very dangerous aneurysm to clip. The third is a ventral wall aneurysm, which is directly opposite the origin of the ophthalmic artery. So it arises from the genu of the ICA, directly opposite to the origin of the ophthalmic artery. And the fourth is a transitional aneurysm, which encompasses all three segments: the supraclinoid, the cavernous, as well as the clinoidal segment. So this is the transitional aneurysm, and this has to be treated based on whether the dominance of the ICA and the balloon test occlusion. Now, there are two very interesting types of aneurysm. Both are seen on the anterior posterior views of the angiogram, carotid angiogram. One is the superior hypophyseal artery aneurysm, which is directed medially towards the sella, and this arises from the junction of the superior hypophyseal artery with the ICA. Now, this points medially, and then there is another one, which is the carotid cave aneurysm, which actually points into which arises from the distal part of the clinoidal segment or the proximal part of the supraclinoid segment of the internal carotid artery, and a large part of its fundus is within the proximal and the distal dural ring. Now, despite the fact that a large part of its fundus is between the proximal and distal dural ring, it still bleeds into the subarachnoid space because a part of this fundus is also in the subarachnoid space. So when you compare the superior hypophyseal artery aneurysm with the carotid cave aneurysm, you find that the superior hypophyseal artery aneurysm is superiorly placed and more distinct from the main trunk of the ICA, whereas the carotid cave aneurysm is more proximally placed, being overlapped by the anterior clinoid process and the clinoidal segment of the ICA, and its neck will not be clearly seen because it will be compressed between the ICA, the trunk of the ICA and the fundus of the aneurysm. That is why its neck is not very well seen. So that is how you can distinguish a superior hypophyseal artery aneurysm from a carotid cave aneurysm. The next part of my talk talks about certain anatomical principles during the pterional craniotomy. So when you're doing a frontotemporal craniotomy, you have this flap which is just anterior to the tragus and then going right across the midline. And therefore, when you are reflecting the scalp flap, what you have to be, how do you preserve the frontal branch of the facial nerve? So the facial nerve, after it emerges from the suture, orbitozygomatic, the suture of the stylomastoid foramen, it comes out from there and then comes on the zygomatic process, and then it passes just superior to the zygomatic process, goes into the fat here, and then comes to the orbicularis oculi and the frontalis muscles here. Now what happens is that if you draw a line from the frontozygomatic suture here to the tragus, okay, so the temporal fascia above this can be left, but below this, both the facial layers have to be taken together because this is in the interfascicular layer. So when you take it below this, then the facial nerve will come within this and will be actually reflected downward, from the zygomatic bone, right? Okay. Then the other very important thing is we all know the pterional craniotomy, but one important aspect of the pterional craniotomy is that whenever you are doing a surgery for carotid ophthalmic aneurysms, one common mistake which a lot of people make is that they do not make a sufficient frontal exposure. So when you make a sufficient frontal exposure, you are not only going transsylvian, you are not only getting a transsylvian corridor, but you are also getting a subfrontal corridor. So this is very, very important that you should actually get a good frontal exposure when you're doing a pterional craniotomy. Uh, of course, you drill the wing of the sphenoid till the superior orbital fissure, and then you expose the dura like this, and then you see the frontal lobe and the temporal lobe and the transsylvian approach and the subfrontal approach that you can combine with the transsylvian approach to get to the tumor. But sometimes what you can also do is you can get a zygomatic, remove the zygomatic arch and reflect it with the temporalis muscle. So how do you remove the zygomatic arch? So one cut you give at the anterior part of the zygomatic arch, one cut you give just anterior to the portion of the mandibular joint here, or with the condyle of the mandible, the joint here. And the important thing is that the capsule of the joint should not be opened, otherwise the patient will have difficulty in opening the jaw following surgery. Then the fascia of the temporalis muscle, the superficial fascia, is attached to the superior rim of the zygomatic process, whereas the deep fascia goes along with the temporalis muscle and is attached to the ramus of the mandible. So if you just remove the superficial fascia and then give cuts on the zygomatic bone, then with the temporalis muscle, the zygoma can be reflected downwards along with the entire temporalis muscle. So this is a very nice way of doing a zygomatic osteotomy. A word about extradural clinoidectomy. When would you do an extradural clinoidectomy and when would you do an intradural clinoidectomy? Except for an aneurysm which is pointing dorsally like this. All the other aneurysms are also amenable to be accessed using an extradural clinoidectomy. So how do you do an extradural clinoidectomy? So you have this extradural frontal dura, this is the temporal dura, this is the globe, and this is the clinoid, which you can clearly see here. Now, what you see is when you are retracting the frontal lobe extradurally, you see a meningo-orbital band here, which is a dural band which extends from the temporal pole right up to the superior orbital fissure here. So as soon as you cut the meningo-orbital band here, then the temporal lobe dura extradurally can easily be reflected off from the cavernous sinus dura, and you can see the branches of the third, fourth, and fifth nerve within its interfacial dural layer. So it's a very simple thing. Just cut off the meningo-orbital band here and then reflect the temporal dura downwards. And that will, and when you are kind of dissecting the temporal dura from the cavernous sinus dura sharply, then you see the anterior clinoid process, which when you drill will get you to the clinoidal segment of the internal carotid artery. So during surgery, so this is the globe, this is the zygomatic osteotomy has been done, and this is the temporalis muscle. This is the temporal dura, this is the sylvian fissure, and this is the cavernous sinus dura. So as you cut the meningo-orbital band, and then you sharply incise the temporal dura from the cavernous sinus dura, you get the entire exposure of the clinoid process, which is represented by the star here. And when you drill this, you get the internal carotid artery just below this structure. Another very important point of anatomy before I actually go on to surgery is how do you get proximal control of the internal carotid artery, which you need in nearly every case of this type. So one of them is you can take control in the neck. The second is you can take control in the Glassock's triangle. And how do you identify ICA in the middle fossa in the Glassock's triangle? By just reflecting the temporal dura till you come to the groove for the greater superficial petrosal nerve. So as soon as you come to the groove for the greater superficial petrosal nerve, you know that the internal carotid artery is just below this. So this part can also be, proximal control can also be obtained here. The third part is that proximal control can be obtained in the cavernous sinus. The proximal control can also be obtained by drilling the clinoid process. So coming from the greater and the lesser wing of the sphenoid, coming from the orbit like this, and then drilling the posterior strut gets you to the clinoidal segment of the ICA, and you can get proximal control here. If the aneurysm is a little distal, you can also get proximal control of the C6 segment of the internal carotid artery. And finally, you can also do a suction decompression, which is you put in an endovascular balloon, your endovascular colleague puts in a balloon into the lumen of the ICA. So as soon as you reach the aneurysm and start dissecting it, he inflates the balloon within the lumen of the ICA and sucks out all the blood through the aneurysm. And that really gives you an access to a non-turgid aneurysm. And this is known as suction decompression, which can also be done. So let's talk about surgery for carotid ophthalmic aneurysm. Let's look at a dorsal carotid ophthalmic aneurysm. And so you see, this is a dorsally pointing, these are the clinoid process. This is a dorsally pointing aneurysm here. You can see it on the sagittal, on the axial, as well as on the coronal images here. And when you look at the CT angiogram, you see that this is pointing dorsally into the frontal lobe. You see the anterior clinoid process, which is partially occluding its neck. And then from an oblique view, you can see this is the dorsum sellae, this is the tuberculum sellae, this is the anterior clinoid process, and this is the aneurysm that you see pointing dorsally and is embedded into the frontal lobe. When you did the angiogram, this is a carotid ophthalmic aneurysm. This is the ophthalmic artery that you see. And this is the large aneurysm which you see pointing dorsally arising from the carotid ophthalmic region. Now, these are beautiful images which actually schematically shows you what we did. So this is the ICA, this is the frontal lobe, this is the aneurysm. You see the proximal part of the neck of the aneurysm is actually hidden by the anterior clinoid process here. And so this is the proximal internal carotid artery, continues as distal internal carotid artery. This is the carotid collar, this is the distal dural ring, and this is the aneurysm which is actually embedded in the frontal lobe. So once we drilled the clinoid process, we came to the proximal portion of the aneurysm, cut the distal dural ring, and then we could easily clip it using a straight clip when we had control of both the proximal and distal dural ring. And a part of the fundus of the aneurysm was hidden behind the second nerve. So we applied a second clip here. So this is what we did. Dissected it from the frontal lobe, dissected it from the optic nerve, saw the proximal portion, and then put in a clip after we had drilled the anterior clinoid process. So let me show you the steps. So this is a frontotemporal craniotomy in which this is the frontal lobe, this is the subfrontal region, this is the temporal lobe, this is the transsylvian area, this is the anterior fossa, cranial fossa dura. Then you see, as soon as we retracted the frontal lobe, you can see this aneurysm covered by its arachnoid. It is seen in the star. And this is the sylvian fissure, this is the temporal lobe. And so we have taken a very good frontal exposure, and this is the second nerve that you see. Then as we go deep inside, we realize that the fundus of the aneurysm is embedded into the frontal lobe, and its neck is hidden by the planum sphenoidale and by the anterior clinoid process, and is extremely difficult to access. And this is the distal internal carotid artery. So obviously we have to drill this portion of the bone in order to get to the proximal segment of the aneurysm. And then how do you retract the frontal lobe to get complete view of the aneurysm? So you'd go subpial. So when you go subpial, you leave a bit of a pia attached to the fundus of the aneurysm, and that way you can easily dissect of the aneurysm. So what we have done is we have gone subpial here. And this is the entire aneurysm. This is the second nerve. This is the lateral approach. This is the medial part. And this is the distal internal carotid artery. So we went subpial and then dissected the frontal lobe from the aneurysm so that we could retract the frontal lobe clearly, easily. After we did that, then the dura over the planum sphenoidale, we cut using straight knife so that we could drill the optic foramen as well as the anterior clinoid process and come to the proximal part of the neck of the aneurysm. So you see, this is the planum sphenoidale, which forms the roof of the optic foramen. This is the anterior clinoid process here. This is the dura, and this is the aneurysm. This is the second nerve. So you can easily, clearly drill the anterior planum sphenoidale, come to the anterior clinoid process, and come to the dura here. So this is the anterior clinoid process which is being drilled, and this is the planum sphenoidale which is being also drilled. And you see, this is the drilled anterior clinoid process. This is the internal carotid artery. This is the large aneurysm that you see here. Now, once you are drilling the anterior clinoid process, then what you are doing is you have actually drilled the posterior strut of the anterior clinoid process. And once it becomes completely mobile, you can actually remove the last portion of the mobile anterior clinoid process. And this is the distal dural ring that you see here. And once you have removed the anterior clinoid process, you see this is the cavernous carotid artery. This is the carotid collar that you see. So this blue arrow is the proximal dural ring. This white arrow is the distal dural ring. This is the carotid collar. And this is the ICA that you see. And a part of the carotid collar is actually covering the neck of the aneurysm. And this is the frontal lobe that you see. So what I'm doing is cutting the carotid collar in order to expose the neck of the aneurysm. And once I have the entire neck of the aneurysm, then I apply one clip over the neck of the aneurysm after making sure that the optic nerve is completely dissected from the neck of the aneurysm. And you see that this is the ICA. So the ICA comes like this, it comes like this. This is the cavernous sinus, it comes like this, and then it becomes distal here. And this is the neck of the aneurysm on which we are putting a clip. And then a second clip is also placed and the aneurysm is opened so that we know that it has been completely occluded. And so you see that the cavernous carotid comes from here, it becomes clinoidal carotid, it becomes supraclinoid carotid from here, and you have applied two clips here. And this is the lumen of the ICA of the aneurysm which has been opened, and this is the frontal lobe here. And so this has been completely clipped and the retractors have been removed from the frontal lobe. So this was a dorsally pointing aneurysm. Now let's look at another paraclinoid aneurysm, which is a giant superior hypophyseal artery aneurysm. You see that this has a laminar structure because the thrombus, partially it is thrombosed and partially it is enhancing. So you see that this is the flow void, which you can see on T2 weighted images. So a part of it is filling and a part of the giant aneurysm is enhancing. And when you did an MR angio, we see that this is the thrombosed portion and this is the filling portion. And you see this is pointing medially towards the sella. The CT angio shows the actual size of the aneurysm. So this is a giant superior hypophyseal artery aneurysm here. The angiogram shows that this is this giant aneurysm pointing medially. This is the carotid, this is the ophthalmic artery. This is the PCOM artery going into parieto-occipital and the calcarine branches. This is the middle cerebral artery. This is the anterior cerebral artery here. So this is the vessel. And when we did a cross flow, we found that the ACOM artery was very patent. So the opposite side was filling. And from the opposite side, the side of the aneurysm was filling, but the aneurysm is not filling, which is a very good sign, which means that if at all, if we have to occlude the ICA, you will still get flow from the contralateral side. And from the vertebral segment also, the PCOM is filling very little of the anterior circulation here, which you can clearly see here. So when you look at these images from the right side, this is the anterior clinoid process, this is the planum sphenoidale, this is second nerve, this is this large aneurysm which is pointing towards the sella, this is ICA, this is anterior cerebral artery, the middle cerebral artery. So after drilling of the proximal clinoid portion, we got to the proximal neck and the distal neck and applied a clip directly on the center of this aneurysm here. So you see, this is the temporal lobe, this is the frontal lobe. We are approaching from the right side. This is the clinoid process here. And so frontal lobe is being retracted. This is the temporal lobe. And when you open the Sylvian fissure, it is always medial to the superficial middle cerebral vein, always medial toward the frontal side of the superficial middle cerebral vein. This is the Sylvian dissection being done. This is the Sylvian vein. This is the frontal lobe, the temporal lobe. The dissection is being done. And as soon as you open the Sylvian fissure, you get the internal carotid artery and the second nerve, and you get the planum sphenoidale here. And then when this is the planum sphenoidale, internal carotid artery, the second nerve. So this is the second nerve going. This is the frontal lobe. And ICA continues like this. It is giving out a posterior communicating artery. And the third nerve goes into the cavernous sinus here. And this is the anterior frontal dura here. Now, when you see this is the second nerve, this is the internal carotid artery, and this is this giant aneurysm with multiple perforators on it. And therefore, it becomes very difficult to reach the aneurysm till you have mobilized the optic nerve. So it's very important to mobilize the optic nerve to get to the proximal part of the aneurysm here. So now what we've done is we are opening the dura over the planum sphenoidale and the clinoid process here. So this is the planum sphenoidale, this is the clinoid process, and this is the cavernous sinus here. And then this is the planum sphenoidale is drilled, this is the clinoid process which is drilled, and this is the optic nerve, this is the internal carotid artery, and this is the aneurysm that you see. So now we are drilling the planum sphenoidale over the optic foramen. This is the anterior clinoid process that you see. And now you see that the portion of the second nerve which is going into the orbit is exposed, and the anterior clinoid process is also seen. Now, further drilling of the anterior clinoid process, the coring of the anterior clinoid process gets you to the rim of the anterior clinoid process here. And this is the cavernous sinus, the blue thing that you see, the cavernous sinus. This is the internal carotid artery here. And now the anterior clinoid process is further being cored from inside. And then the last part is being removed using dissectors. And after the anterior clinoid process has been removed, you see that this is the second nerve with its portion of the optic foramen also being exposed. So this can be easily mobilized. You have the ICA here. You have the distal dural ring, then the carotid collar, which takes you to the cavernous sinus here. So this is the proximal dural ring. This is the distal dural ring. This is the carotid collar, and this is the entire ICA going into the cavernous sinus here. So the next thing is to open the carotid collar, which can easily be decompressed, because you can easily decompress this carotid collar here. So once you do it up to the proximal dural ring, you get about 8 millimeters to 1 centimeter of the internal carotid artery, which is curving like this and covering medially into the cavernous sinus. So this is the optic nerve here, optic nerve. This is the internal carotid artery. This is the carotid collar and the distal dural ring. You are cutting it up to the proximal dural ring and just proximal to the cavernous sinus. Now you have the ICA going like this, and this is the beginning of the cavernous sinus here. So you have exposed a little bit of the ICA. Now, as soon as you do that, it is possible for you to mobilize the second nerve and come to the proximal aspect of the aneurysm. So this is the internal carotid artery, and this is the entire aneurysm, the proximal part of the neck of the aneurysm. This is the distal part of the neck of the aneurysm, and you have this whole aneurysm in front of you. So you apply a clip. This is the second nerve. You apply a clip from here to here, from the proximal to the distal segment of the aneurysm, and making sure that the first clip is distal to the ICA. So the first clip is a little distal so that you do not occlude the lumen of the ICA when you're applying this clip. And then this clip has been applied. So this is the aneurysm. This is the second nerve. This is the internal carotid artery. This is the PCOM artery. This is the cavernous sinus. And the first clip has been applied on the neck of the aneurysm. And then the second clip is also been applied. And you see, this is the part of the aneurysm that is, and you see the ICA. This is the proximal part of the ICA, the clinoidal segment of the ICA. This is the supraclinoid segment of the ICA. This is the PCOM coming out of it. This is the carotid optic space. This is the second nerve, and this is the cavernous sinus. So you have applied 2 clips on the neck of the aneurysm after exposing the neck by mobilizing the second nerve and by drilling the clinoid. Now the next point is to put in a needle into the aneurysm to make sure that the aneurysm has been completely controlled, but never mobilize the fundus of a giant aneurysm of the suprasellar area, because it will shrink gradually with time. But if you try to mobilize the entire fundus, then the perforators will come in your way and they will cause hypothalamic injury. So then with scissors, you open the fundus of the aneurysm and remove the clot. So you see that the clot is being removed from the fundus. These are the clips placed on the neck of the aneurysm. This is the ICA, and this is the second nerve. And this is the surgery. Following the surgery, you see following a right frontotemporal craniotomy. And there's a post-op angiogram, which shows the ophthalmic artery here. You see the PCOM artery is safe here, the parieto-occipital and the calcareous. This is the middle cerebral artery, and this is the anterocerebral artery. So you can see that all the vessels are completely safe when you're putting both these clips on the aneurysm. The third is a very interesting case of a dissecting paraclinoid segment aneurysm. So here you see that this patient had IC angiogram, AP and lateral view. You see that this is a dissecting aneurysm, and beyond the dissection, you see the posterior communicating and the parieto-occipital and the calcarine branch of the PCA, but you do not see the ICA. So this patient was taken into the angiogram suite, and what we did was, and you see that the whole margin of the ICA, supraclinoid ICA, this is the anterior clinoid process, the whole margin of the supraclinoid ICA is so irregular here. And this is the supraclinoid ICA, which is not seen on the angiograms because of spasm. So we took this young girl who had come with hemiparesis into the angiogram suite, and there we put papaverine, instilled papaverine into the ICA. And once we did that, then the middle cerebral artery opened up and the anterior cerebral artery opened up on this side. But as soon as we brought this patient out, again there was a spasm and the patient developed hemiparesis again. So again, we took the patient into the angiogram suite and put more papaverine, intra-arterial papaverine. So you see again, when we did this angiogram, you see that the MCA is not completely seen and the ICA is not completely seen from here. It's very, very narrow. MCA and ACA is very, very narrow. Again, it has gone into spasm. So with this papaverine, then thankfully the middle cerebral artery and the anterior cerebral artery opened up again. And then we could take up the patient, young girl for surgery. And here what we did was that this is a left-sided frontotemporal craniotomy. This is the frontal lobe, this is the temporal lobe, this is the anterior clinoid process, this is the optic nerve. And you see that this dissecting aneurysm, it did not have a neck, and it was arising from the ICA like this. So once we drill the anterior clinoid process, cut off the proximal and the distal dural ring, then it was just possible to clip the large wide neck of the aneurysm and put a lot of BEM sheet over the remaining abnormal part of the ICA. So this is the frontal lobe and the temporal lobe. This is the left-sided surgery, and the second nerve and the ICA is exposed. And you see, this is how a dissecting segment of the ICA looks like. It looks so red and abnormal. So further dissection got us to the anterior cerebral artery. This is the ICA. And you see that this whole thing is so irregular. And this pseudoaneurysm, you can call it almost without a neck, is arising from the ICA like this. You see this? It is arising from the ICA like this, and the proximal part is hidden. So we drill the anterior clinoid process, and then we clipped the aneurysm. You can see the aneurysm being clipped. So you can see this is the proximal ICA, this is the distal ICA, this is the optic nerve, and this is the carotico-optic space. So we could actually gently, very, very gently clip this aneurysm to get it out of the circulation. But you see that the proximal ICA is also abnormal. So we first punctured the aneurysm to make sure that it had been properly clipped. And then we put BEM sheet over the proximal and the distal ICA and put fibrin glue over it in order to reinforce this abnormal segment of the ICA. My final example is a bilateral superior hypophyseal artery kissing aneurysm that you see here. And you see that this is the angiogram of this patient, and you see the MR angio. You see that there are kissing aneurysms, both of them pointing medially and with their fundi kissing each other in the suprasellar cistern. And here we utilized a unilateral frontotemporal craniotomy to actually get to the aneurysm. So we did a T-radial craniotomy. First we reconstructed the ICA. So you see the ICA is coming out from here. This drilled the anterior clinoid process, reconstructed the ICA, reached the distal portion. This is the anterior cerebral artery. This is the middle cerebral artery. This is the giant aneurysm. We reconstructed the vessel using fenestrated clip. Then we drilled the planum sphenoidale and the optic foramen on the opposite side, and then clipped the medially pointing ICA aneurysm arising from the ICA on the opposite side. So when we look at the angiogram, you see this is the second nerve, this is another second nerve. You see that this is the one aneurysm, this is the second aneurysm. Both of them are lifting up the optic nerve, and this patient presented with bilateral visual deficits. So we drilled the anterior clinoid process. This is the proximal ICA. This is the distal dural ring. This is the ICA. This is the anterior cerebral artery and the middle cerebral artery. This is Sylvian fissure. This is the suprasellar cistern. So this was one aneurysm with giant aneurysm with a wide neck, which was ipsilateral to the aneurysm. And this was another aneurysm on the opposite side. Using fenestrated clips, we first reconstructed the ICA and clipped the aneurysm on the ipsilateral side. Then we opened the planum sphenoidale, the dura of the planum sphenoidale, decompressed the optic foramen, drilled the planum sphenoidale here, reached proximal to the neck of the second aneurysm on the contralateral side, and clipped it using two clips from the ipsilateral side. So using the left-sided surgery, we could clip both the left and the right-sided aneurysm. So this is a left frontotemporal craniotomy. This is the Sylvian fissure, this is the frontal lobe, this is the temporal lobe. This is the anterior dura here. And you can see the second nerve, the ICA. You see this star is the suprasellar part of the aneurysm, which is arising from the ICA. You can see the distal part of the neck of the aneurysm here. And this is this whole giant aneurysm here. And then this was further dissected. You can see the aneurysm, second nerve. You can see the planum sphenoidale. and this is the ICA here. This is the frontal lobe, which you can clearly see. Then we drill the planum sphenoidale to get to the proximal segment. And after drilling, you can see that the proximal part of the second nerve is completely free. You can see that the ICA is completely free. You can see that the ipsilateral aneurysm, so ICA comes out like this. ICA is coming like this, coming like this, coming like this, and coming like this. So one part of the aneurysm is toward this side. The second part of the aneurysm is in the suprasellar cistern here. And the contralateral aneurysm you can see here, which is covered by the planum sphenoidale of the opposite side. So it's very, very clear here that this is the ipsilateral aneurysm. This is the ipsilateral aneurysm on the opposite side of the second nerve. This is the contralateral aneurysm on the opposite side. And this is the planum sphenoidale that you see. And this is the optic nerve that you can clearly see over the aneurysm. So the first clip was applied, fenestrated clip was applied, which was taking the neck, which was taking the lumen of the fenestration was preserving the lumen of the ICA and taking the neck of the aneurysm, of the ipsilateral aneurysm. This is the contralateral aneurysm, and this is the drilled planum sphenoidale. So you can clearly see that 3 fenestrated clip have reconstructed the ICA of the ipsilateral side here. And you can see this, and then you can also see that they are completely occluding the ipsilateral lumen of the ICA. And this is the contralateral aneurysm, which is clearly seen. And this hash represents the planum sphenoidale, which covers the ICA. So having taken care of the ipsilateral ICA by these 3 clips here on the ipsilateral side, you can clearly see the contralateral second nerve. You can clearly see the contralateral carotid-ophthalmic superior hypophyseal artery aneurysm pointing medially, and you can clearly see the planum sphenoidale here. So now this planum sphenoidale is drilled. This is the second nerve. These are the clips. This is the contralateral aneurysm. You can see the contralateral second nerve, which is lifted up by the aneurysm. Now we are drilling the planum sphenoidale on the contralateral side. This is the contralateral ICA, the contralateral aneurysm, and the second nerve that you can clearly see here. This is the ipsilateral second nerve. So now we are actually drilling the contralateral planum and then dissecting the planum off so that we have deroofed the optic nerve, we have deroofed the proximal part of the ICA, and now we are getting the contralateral aneurysm, the proximal part of the contralateral aneurysm. And then we have applied a clip to the contralateral aneurysm from the left side. So this is the right-sided aneurysm. This is the contralateral ICA. This is the proximal part of the neck of the aneurysm. This is the distal part of the neck of the aneurysm. And the clip has been applied to the neck of the aneurysm here. And once this is clipped, you can completely see the contralateral ICA, the proximal part of the ICA, which is continuing into the anterior cerebral artery. And this is the neck of the aneurysm, which has been taken up by the clip. So the final picture is that this is the ICA, which is completely preserved. And this is the contralateral clips on the neck of the aneurysm. This is the ipsilateral ICA, which has been reconstructed using fenestrated clips. And this is the optic nerve, which is between the contralateral clips and the ipsilateral clips. So with a single approach, we have approached both the sides, and you can clearly see the entire thing. This is the ICA, this is the optic nerve, this is the ipsilateral optic nerve. These are the clips which are reconstructing the ipsilateral ICA, and this is the ipsilateral middle cerebral artery. So it is possible to approach a medially directed aneurysm of the opposite side from the ipsilateral side. And this is an acute bleed, so this is post-surgery. Now, one small strategy which I wanted to tell you, you can mobilize optic nerve further to get to an aneurysm which is pointing further medially by drilling the planum sphenoidale on the medial side of the second nerve also. You can drill that and actually come to medial side also. So you can get further mobilization, and you can get to an aneurysm which is actually deep within. So an aneurysm which is deep within, you can also mobilize the optic nerve further to get to the fundus of the aneurysm. So you see the optic nerve when you're approaching from the right side, you can see that the fundus of the aneurysm is deep within. But what we have done is we have drilled the planum sphenoidale up to the sphenoid sinus. So once we have done that, then we can actually mobilize the optic nerve and see the entire aneurysm below the optic ICA, and then you can actually clip it there. We can easily clip this aneurysm there. And this is one strategy. And the second is that if there is an ICA here and the aneurysm is on both sides of the ICA. So you see, this is the ICA here. So this is aneurysm of this side. There is an aneurysm of this side, and this is the cavernous sinus. This is the optic nerve. So once you have mobilized the optic nerve, you have this aneurysm of both sides, which you can reconstruct using right-angled fenestrated clips, which preserves the lumen of the ICA and takes the aneurysm there. So you can see that a right angle fenestrated clip has taken this. You can see the preserving the, and then right and the straight clips are taking the lumen of the aneurysm. So the ICA is completely preserved, and this fusiform aneurysm can easily be preserved using this clip. Now we've had some failures also. The last part is failures. You see this proximal ICA segment aneurysm. So this is a dorsally directed aneurysm. So this is a dorsally directed aneurysm, which was like a button. So you see that I just wanted to show this is an acute bleed, and I thought I had done a very good job with the dissection. This is the optic nerve that you see, and you see that this is the aneurysm that you can clearly see. This is the aneurysm that you see. This is the ICA, but you see, when you see a pseudo aneurysm like this, and you think you've done a great job here, and I thought I had got the proximal neck, I thought got the distal neck here, and I'm just applying the clip. And you see what happens when I'm just applying the clip. So as soon as the clip is applied here, the clip, I thought perfect position to apply a clip, one proximal, one distal, very gently, and then suddenly the whole thing avulsed. So then I had to take proximal control in the neck. Just the whole thing got avulsed. You see the whole fundus got avulsed. And so we have put proximal and distal clips, and then just the fundus got avulsed here. So just remove the clip, and you see it's impossible to reconstruct this. So what we did was that we applied small fenestrated clips, which took a part of the lumen of the vessel, and then rest of the lumen was intact. So luckily for us, having done that, it was possible for us to see. You can see that with right angle clips, we just preserve the lumen, and so you see the lumen is preserved here, and lumen is preserved, and then we remove the proximal and distal clips, and this patient did reasonably well. This is another aneurysm, and here this aneurysm had a very interesting direction. When we looked at this patient, this was directed anterior-inferiorly and was embedded in the tuberculum sellae. And when we went through a frontotemporal craniotomy, there was no way we could actually get to the aneurysm. So what we did was, with a frontotemporal craniotomy and Transsylvian approach, all we could do was, we kept on struggling, but we could never reach the antero-inferiorly directed aneurysm. So
sorry for the interruption, sir.
Yeah. Last two slides.
Please, sir. Yes.
Yeah. So we went on struggling, but we could never reach the aneurysm. So we just applied a clip. And this is a giant aneurysm where we did a vessel reconstruction here. But this was using, so we drilled this, did a vessel reconstruction, but this patient, we had, and you see that, so you see it, he already also had an ACOM artery aneurysm, which we clipped. So this is the ACOM artery aneurysm. First, we clipped the ACOM artery aneurysm. So this is the gyrus rectus being dissected from the aneurysm. You see that this is the ACOM artery aneurysm. This is the ACOM. This is the A2s on both sides. And having clipped this one, you see this is the ACOM which is coming here. So we clipped this ACOM artery aneurysm, and then once we had clipped this aneurysm, then we punctured it to make sure that it has completely gone. And then the next one, when we did a dissection of the carotid ophthalmic, you see that this is this huge carotid ophthalmic aneurysm here. And we drilled the planum sphenoidal clinoid, and you see how it has kind of involved the. So we dissected it from the optic nerve, made sure that we are distal and proximal. You see, it is beautifully seen. You can see the lumen. You can see this, and we build this. These the planum, and so you see, we've gone proximal to it. You see the neck of the aneurysm. You see the fundus. And we are trying to put fenestrated clip. This fenestrated clip is again and again getting slipped off. So what we did was we ruptured the aneurysm, and then put fenestrated, reconstructed the vessel using fenestrated clips. You see, it is very difficult to do it unless you rupture the vessel. So once you rupture the vessel, then you can reconstruct the complete vessel here. So this was the final image. But this patient developed a hemispheric infarct, and we had to do a decompressive cranectomy. And of course, he didn't do well. So therefore, in a superior hypophyseal artery aneurysm of this type, you do not need to see the proximal vessel simply because there is a plexus there, and there are multiple vessels which are supplying the pituitary stalk and the hypothalamus. So you don't really need to preserve the parent vessel when you actually deal with the superior hypophyseal artery aneurysm. And so, as Professor Kenichiro Sugita said, surgery, like science and art, has no end, and most of it is agony itself. Thank you so much for giving me this wonderful opportunity. Thank you so much.
Thank you very much, sir, for your wonderful talk as usual.
Thank you, sir.
Dr. Sridhar.
Yeah. Dr. Sanjay is excellent talk, and I can understand your first slide when you are thanking your illustrator. Definitely, the illustrations are excellent.
Thank you so
and
much.
Very good for teaching purpose. Really, they reminded me the Netter's atlas. So nice they are.
Dr. Priyadarshi is an outstanding
Yes,
artist. She's a fine surgeon and an outstanding artist.
Yes, excellent artist, sir. Thank you very much for the nice teaching video. And next talk we will go, because we are running behind schedule. So I'll request Dr. Satyarana to invite Dr. Jogi.
Thank you so much.
Thank you very much.
Thank you, sir. Good morning, sir. I invite Professor Jogi V. Pattisapu. He is a pediatric neurosurgeon, presently professor at Bennett School of Biomedical Sciences, University Central Florida College of Medicine. He was a founding emeritus medical director for pediatric neuroscience, Arnold Palmer Hospital for Children, founding medical director for pediatric neurosurgery at Florida Children's Hospital. He had his basic education in science at the Houston Baptist University, MD in University of Texas, intern at General Surgery, University of Mississippi, resident in neurosurgery at University of Mississippi, and fellow in pediatric neurosurgery in the University of Utah School of Medicine. And he was American Board of Neurosurgeons certified and American Board of Pediatric Neurosurgeons certified him twice in 1997 and 2006. He has several presentations in national and international journals, and been in private practice from 1990 to 2010. His professional associations has an exhaustive list. He was president and chairman for several associations. And industry experience, he developed the Medtronic PS medical shunt between 88 and 92. He was an expert panel for intrathecal baclofen pump, consultant for Integra Research and Development. And with this few lines, I request Professor Jogi V. Pattisapu to start his lecture.
Namaskaram, Andy, and good morning. I think we're starting about 25 minutes late. We have a president's
Very sorry, sir.
oration.
Very sorry.
No, you have to maintain for the president's oration. That's important. Namaskaram, Andy. I'll do my best. I'll cover the first part and hopefully share some things about hydrocephalus, which not as exciting as some of the other things as tumors and vascular, but unfortunately very common, especially in the developing world and in the pediatrics. The main issue is that we can still learn from our predecessors because we don't understand everything. in this group as well as in combined experience will give a lot. Some simple examples. We'll just cover about 4 or 5, 6 topics to make it happen. Friends, I'm very proud to see the Indian contribution to global neurosurgery in the past decade, 2 decades. You have now come on the world stage, as we just heard Professor Sanjay excellently showed. He matches everything else you see from Phoenix to everywhere else. So very nice to see. The topics we need to talk about are some pediatric hydrocephalus, some adult issues in NPH, which is now increasing around the world, the use of programmable antibiotic shunts, etc., and some endoscopy, which has a role to play. A few scientific concepts. The main problem we have is that most of our science in hydrocephalus is clinical and device-oriented. I believe it's something wrong compared to other fields. We need more basic science, so I'll touch upon that if time allows. And we have multiple manifestations of this condition, which we need to somehow make it better. If we can come out with a combined theory of hydrocephalus and CSF homeostasis, friends, I think we'll do a better job, and I hope to do some stimulation to rethink our understanding. Unfortunately, we have a lot of theories, some suspicions, but we really don't understand it because our knowledge is very, very limited. But we should have the confidence, like Zig Ziglar said, if you're going after Moby Dick, take along the tartar sauce because you will win. We hope to win. Here's a simple understanding of the many causes of brain fluid accumulation, otherwise known as hydrocephalus. But it's anywhere from trauma, which is increasing. More patients are surviving that. More patients are surviving intraventricular hemorrhage as babies and infections. And we have now survival rates higher. Therefore, the incidence is higher. There are lots of theories about environmental causes, especially in NPH and the increase in tau protein and the problems with our adult problems with NPH. And still a huge unknown. We're not sure we know what causes it. It can cause it through some problem in the cell or directly block the CSF absorption. And the problem we have is that we have infinite shunt operations thinking that's the only cure. So we have a problem. Interesting that most of the data are from the West. However, the problem is heavily outside the US and the West. India, as our good friend Venkatraman has written from Bangalore, yes, you have a good number. And I have operated in India, Uganda, Ukraine, other places. And we have a tremendous understanding. And friends, the #1 shunt used in the world today is still the Chabra shunt. So India's contribution is huge. And the experience, and if friends like you and others will find a better way, hopefully you'll be able to teach us to rethink how we approach this. And as I said, the only treatment is shunts, and more shunts, and occasional endoscopic third ventriculostomy. But the graph on the top shows that there's a continual failure, especially in the young babies, but even in the adults. 50% of shunts will fail within 4 to 10 years. Within 2 years, we have a significant number of them fail. And if we think about it, we would not be happy if we took our car to the mechanic and we have so many recurrent problems. We'd be so unhappy with the car mechanic, but yet our patients still trust us. Some of them are they're avoidable complications and misjudgment, but a lot of them could be to improve infections, which I'd like to talk about. And unfortunately, a shunt is like a diamond, it's forever. And it's very, very difficult, but we should do our best to keep these complex patients out of the hospital and out of the OT as best as we can, if we can find better ways. At this time, this is my secretary's hand with the pile of shunts that we have that we can say plenty of. And I like this quote from Professor Ashoff: "Man, we should not use bad valves or misguided valves." And I always used to use this joke for my residents and students. Hydrocephalus, the definition, means hydro means shunt, and cephalus means malfunction. So it's the life of neurosurgery with hydrocephalus. Programmable shunts have made a good progress for us, extremely expensive, unfortunately. But in my humble opinion, only about 15% or so of patients absolutely need a shunt that can be programmed. Unfortunately, we don't know which ones they are. But for NPH patients, they're absolutely godsend. They help prevent the subdural hematomas. And I hope and we'll find a better way to make these less expensive so that we can have more use of these things. The new shunt by the Johnson & Johnson, now the Integra system, has a virtual off, which is very, very important. It's at about 400 millimeters of mercury. So if you're trying to wean somebody from a shunt or even get rid of a subdural hematoma, use of this valve with the Certas programmable valve having a very high virtual off can help us maybe wean the shunts in the future. The antibiotic shunts, nice studies. There are some improvements. I would like to show our colleagues who are not familiar with Maurice Chou's work from France. Beautiful work, and he came out, we were shocked. He had 600 patients with very, very low infection rate, and then another series with 0 infection rate. And Maurice was flamboyant, but he had certain rules. That is the first case in the operating room, which is hardly ever given to a shunt. It's always the tumor or vascular cases that get it. So like that, to avoid complications and paying particular attention can help us reduce shunt infection rate, please. The antibiotic impregnation with it's actually supposed to be rifampin, sorry. The rifampin and clindamycin and et cetera are very well. And I'll speak a few words about the BASICS trial. The results just came out last year, a very nice study done in England with several thousand patients in each arm with no shunt antibiotic impregnation, the standard, the rifampin and the clindamycin, the Bactiseal shunt or the Ares shunt, if you will, or a silver impregnated. There was a 6% to a 3%, a 50% decrease in shunt infections, if you would. But interestingly, the silver impregnated ones didn't do as well. However, I would like to also quote my dear friend Ben Worf, and I worked in the same hospital that he mentioned for a few weeks, in Uganda. His last paper did mention that in Uganda, where infection rate was very high, he did not find it to be a statistically improvement using antibiotic shunts. So it is a good idea if you have a very high infection rate, meaning 10, 12, 15%, you can bring it down to 5% or so. But if you have a 5% or 8% shunt infection rate, you may not see the benefit. The idea of a smart shunt is around the corner. We always dream of a shunt, and these are multiple requests, the basic need that we want for the shunt companies to most importantly make it cost effective, of course, which is impossible. But we have technology already, friends. We have technology, it's called a lab on a chip. We can send man to the moon. We can do all these technologies. I went to NASA and worked with them because I live in Florida and NASA's down the street. Yet we're not able to find the resources to find the various things we need. A shunt that will monitor pressure and tell us about flow. It'll tell us about obstruction, self-adjusting maybe, waveforms. These are all things we would love to have in a shunt that doesn't give us more hardware to deal with, but hopefully it'll work. It's a dream of the future. And the Hydrocephalus Association gave $250,000 to develop this. Sansia's smart shunt device is still being developed. Endoscopy, it's been around since over a decade, over 100 years, over a century. And since now used multiple techniques. Les Binet first used the pediatric urology cystoscope, which is interestingly, that's the one I was trained in by my mentor, Jack Walker, back in the 80s. That's the first scope we used to do a third ventriculostomy. With a flexible or a rigid endoscope, There are trade-offs, but you need to have a nice steep learning curve. The flexible endoscope gives you the advantage of doing, seeing around corners and maybe doing choroid plexus coagulation and even other septations. And it seems to be much more usable, but it does take some getting used to and training. And the optics are naturally much better with the straight lens scope as opposed to the flexible. With the endoscope, there's still questions. We don't know what's the best use for them. Should we add a CPC, choroid plexus coagulation? Should we find a better way of doing it? And how long do you follow a patient after ETV? How successful is an ETV? How big does a third ventriculostomy opening have to be? Most people feel it must be at least 5 to 6 millimeters, and there should not be any arachnoid adhesions for it to be successful. The word is still out if endoscopic third ventriculostomy is beneficial in NPH. The Italian study and subsequently other studies are still equivocal. I'm not sure why it would work, but it has been tried and there's some proof for it. As always, what is the best age in a baby for endoscopic third ventriculostomy? I'm sitting before you. I have done them in babies less than 2 months old in Uganda. Successful. I was very pleased. And you can do them. The anatomy is different, but you can do successful ETVs and choroid plexus coagulations in babies, 4 to 6 kilograms in size and 2-3 months of age. Many still unanswered questions about hydrocephalus. What is the function of CSF? Why do we have CSF? I'll touch on that later if we have time. Friends, I would like for you to think of one thing, please. 15% of our cardiac output goes to the brain. Almost a liter a minute goes to the brain. Most all of it comes back, except for a very small amount. 0.33 mil per minute is left up to be made as CSF, which is about 500 mil per day. If we think that the child or an adult is having trouble absorbing 1/3 of their spinal fluid, meaning 0.1 mil, that's 30%. The patient may be in trouble. The only thing we can offer them is a shunt. Is there a way we can teach somebody to absorb 0.1, 0.2 mil of CSF per minute? I'm sure it's not that much. If you think of a syringe, it's a small amount of fluid. We have not yet spent enough resources in teaching the brain to absorb its own fluid. We can find better ways to reduce infection risks. We have so many protocols. We have so many methods. Why is it 30% in some places and 6% or 0 for shunt infections? We can find a better way. If we saw beautiful pictures of aneurysm clippings, everybody around the world does the aneurysm clipping essentially the same way. Taking out a tumor, we do it the same way. We don't seem to have the answers for hydrocephalus for some reason. And can the shunt be maintained long-term? Can one shunt last 10, 15 years as opposed to so many? And yes, there are patients who've had 100+ shunt operations by the time they're 10 or 12 years old. I've seen them, I've taken care of them, and it's called a century club of such patients, young children who've had hundreds of shunt operations. We developed this technique a long time ago called a percutaneous endoscopic recanalization of the catheter. You can see this endoscope here. It's 0.5 to 0.8 millimeters in diameter. It goes into the shunt actually, and you can see an obstruction in the shunt proximal. This is a live patients. I didn't insert the videos, but you use a small Bugby wire to go with it. And once you coagulate it, the lumen are open and the CSF is flowing. Here you can see the CSF coming out after we coagulate. It's a modified shunt tap. It takes 10, 15 minutes or maybe 8 minutes. It can be done outpatient and it's actually wonderful. But the question is, how long will this stay open? And to our studies, it has stayed open as long as there's regular shunt open shunt provision. Some other questions left in pediatric hydrocephalus. What type of a shunt? Should we use a programmable shunt or non-programmable? Antibiotic impregnated, is it necessary? Is it worth it? Many studies say it's worth it for the cost in the long term if you can afford it. Shunting is a multi-billion-dollar industry in America. Of course, in India and other places where the infection rate is high, we can reduce it by doing this. In pediatric, the common question is it benign ventricular enlargement without any symptoms, or is it true hydrocephalus that need to be operated? Every week we see such patients, the dilemma of yes or no. There's so many factors, but in the interest of time, I'll mention to you is just that all the typical signs of continued follow-up, because committing a baby to a shunt is, of course, high risk. Use of shunt protocols, there are enough research data to show if we all did something the same way, then it'll come out to be better. Unified shunt protocols developed by the Pediatric Research Network out of Seattle has been very beneficial, very beneficial. For NPH, we have tremendous improvements in MRI technology, and they're able to give us better definitions of who needs a shunt and who doesn't. Protocols for how to develop a shunt, how to develop a methodology for identifying a candidate is important. We do it by team meetings in a committee, and the group decides, including psychologists, therapists, neurologists, developmentalists, everybody decides which patient has the proper need. In this bottom left picture, you see the callosal angle. If it's more than 40 degrees, you worry. If there, of course, transependymal flow, there are other flow findings in the aqueduct. These are all extremely important to separate it out from DESH, DESH, the fluid over the brain. These are all conditions. If we can identify the right patient before the mental changes, NPH patients often respond very, very well. Many protocols and the neuroradiologists are now identified a very, very nice set of parameters separating atrophy and dementia like Alzheimer's versus a hopefully treatable patient with NPH. Having said that, we're still only finding 5 to 10% of patients with Alzheimer's that should and could improve with shunting. A couple of words about brain turgor. This is a interesting concept, is B sub T. The brain is like a sponge. It can be soft, it can be hard. And in patients who have, for example, benign intracranial hypertension or pseudotumor cerebri, their brain is very stiff. The pressure inside can go tremendously high. The ventricles may not get larger. And if we think about all the changes within the actual fibrils that hold the neurons and everything together, it's a matrix that can be stiff. And if it becomes stiff, then you have conditions such as a split ventricle syndrome, which we may cause by shunting somebody and draining too much fluid. We need to understand this in relation to the vascular changes and the pulsatility, which I'll talk to you in a minute if we have time. This is the same slide I showed you a minute ago. I'm trying to move fast in the interest of time so we can get to the presidential address. The main consideration is, can we find a better way to see at the cellular effect the problem? Friends, the problem we have is that the basic understanding is that the CSF is made in the choroid plexus, and the green fluid, as you see circulating from the choroid plexus, it goes to the arachnoid villi, should be absorbed at that level. Why do we have CSF? What does it do? Is it a byproduct of life? Is it a transport mechanism? We have CSF doing all the work before the vessels are even developed in the brain. Is it help you with shock absorbers? Is it a messenger system? These are all unanswered questions we should know about. If you think of arachnoid villi, because we had them from Dandy and Blackfan a century ago, friends, we do not have arachnoid villi in babies and children. That I've thousands and thousands of operations, but my babies and children don't have arachnoid villi. They don't have those descriptive surfaces where CSF should be absorbed. At the most, they have some temporal pits. That's it. So the CSF is probably being absorbed in many other places, including the choroid plexus. Part of our limitation is simple. We don't have animal models to tell us how to do this better, that we can extrapolate to the humans. Here I just circled the Hydrocephalus texas rat up here. and the several mouse models, especially mouse, which we know has hydrocephalus due to the hidden gene problems. These two animals we've used in our labs as well, and especially the HTX rats. I'll show you some. Most recently, last year, we had a new model that came out with a specific genetic abnormalities, but unfortunately, this is not yet tested as well. And this is the HTX model. By the time the animal's 10 days old, you can see the hydrocephalus and the animal's already affected. You can see that day 4, there's a sign, you can pick up an early sign compared to the normal one. And yes, this is a 4-day-old pup that I put a shunt in. You can keep them alive for a year with a shunt. Here's the ventricular right there and the abdominal portion, and it's a PE10 tube, but they can work, they live. Just so I'm an expert in rat shunting. It doesn't mean anything. I've made the same mistakes in rats I have with taking care of humans. Fred Epstein, bless his heart, a world-renowned pediatric neurosurgeon, said, look, it's a dream. Tim George, the predecessor to mine, pediatric neurosurgery editor-in-chief, same problem, how can we do this? And most recently, we lost Jim Goodrich last year due to COVID, or this year, excuse me, due to COVID. And he said the same thing. What is the change? Nothing in 1,500 years. To my benefit, to my good luck, Dr. John Holter, the man who invented the shunt, as you see him here with his son, Casey, who had the first shunt inserted back in the 50s, came to my lab, started my efforts, encouraged me tremendously, and told me one thing simple. All hydrocephalus research stopped with the shunt.
They're ready to start a presidential oration, sir.
I am ready to stop. Thank you so much. I'm sorry that they took up my time with somebody else, but you all have a wonderful day. Thank you so much for the opportunity.
Thank you, sir.
Thank you very much, sir. Thank you very much for your nice presentation.
Thank you, Katis. What to say? Let me take the occasion to introduce you, sir. You are all Manas Panigrahi, sir, doesn't need any introduction actually. He has done his higher secondary school education at Government High School Medical Campus, Behrampur, Orissa. Then he has done his MBBS in MKCG Medical College, Behrampur, MCH from National Institute of Mental Health Sciences and Neurosciences, Bangalore, NIMHANS, Bangalore. He has done his senior residency again in NIMHANS. Then started his profession as assistant professor in NIMS, at NIMS in Hyderabad. Then moved on to do skull-based and cerebrovascular fellowships at Wayne State University. Came back to work at NIMS as associate professor, then additional professor, and then professor. He moved to KIMS as consultant neurosurgeon and HOD in 2009, and he is working at KIMS since then. He has taken part in lots of academic activities all over India. He has published many articles and written many chapters in books. He has conducted many great conferences, both international and national conferences. Sir, now I would like you to start your presentation.
Yeah, thank you, Dr. Varaprasad. Then thanks for inviting to give a lecture on a very common topic. Decompressive craniectomy is commonly done every day, but the technique and the complications are not reported. Then when you look at the literature, not many papers on the complications are reported. Recently, only in the past 3-4 years, we have reports on the complications. So I thought I'll use this topic because this is a surgery which we do every day. Can you see my screen?
Sir, not seen, sir. Your screen is not seen.
Not seen. Okay. Okay, now it is seen.
Yeah, yes, sir. Now it is seen.
Okay. So you can hear me and you can see the screen, no? Now?
Yes, sir. Yes, sir. Hearing and seeing.
Okay. So complications of decompressive craniotomy. This was a textbook article just published 5 years ago. They have listed early and late complications. Then this paper came in 2010, where they analyzed the different complications of decompressive craniotomy for traumatic brain injury and how to deal with it. The commonest complication in decompressive craniotomy, what is reported is CSF related, like subdural effusion is almost 30%, 32%, and followed by post-traumatic hydrocephalus 11%. So the CSF related complications are almost to 40%. Plus you have 10% incidence of syndrome of the trephined or sinking flap syndrome, and there's a significant complication also of cerebral herniation. External herniation if one does not do the proper size of craniectomy. If one does a small one, then there can be cerebral herniation also. Knowing that so much of complication, 40% incidence of CSF related complication, 10% seizures, 10% herniation, is it worth doing decompressive craniectomy? If one looks at the literature review till 2005, it was very controversial. One can see that people reported favorable outcome from 4% in 1976 to 78% in 1990, and it came down to again 16% 2005 and 61%. So it's the outcome of decompressive craniotomy has been variable, starting from 4% to 80%. So it was not clear whether it is worth doing this kind of procedures and having so many complications also. In 2011, there was a trial which was published, DECRA trial, where they said that people who had ICP of more than 20 mm, when they did a decompressive craniotomy, whether they were treated medically or surgically with decompressive craniotomy, their mortality was similar. Like surgery had 19% and non-surgery is 18%. So this did not actually had any benefit of reducing mortality. Rather, they increased the number of vegetative state patients. So they say that it is unfavorable to do a decompressive craniotomy. But then another trial, rescue trial, which started in 2006 and then they published in 2016. Rescue trial is randomized evaluation of surgery with craniectomy for uncontrolled elevation of ICP. They did the study for 10 years and published in 2016. And they analyzed the outcome depending on the Glasgow outcome scale, where independent at home is taken as the upper severe disability. So if somebody is independent at home following surgery, one has to take it as a good outcome. Whereas vegetative state or severe dependent on others is not taken as good outcome. If one takes this measurement parameter, what they saw that at 6 months in the surgical group, they improved from 34. In the medical group, there are 34% who were independent, whereas in surgical group, 42% were independent. 42 plus 30, like 70% were independent, and whereas in the medical group, it is far less. But then it was not statistically significant. When they followed up the patient for 1 year, the patients who were independent increased from 32 to 45%, and patients who were vegetative from 15 to 24%, and mortality reduced from 50 to 30%, and this was statistically significant. So this paper, Rescue Eyes trial, it confirms that decompressive craniotomy is worthwhile doing, but then one can achieve good outcome by only taking care of the complications. As the people who survive, 40% of them, they'll end up with some form of complications, and one can only achieve good results by either avoiding or managing these complications. And all of us daily have encountered similar some complications in these kind of patients. The complications can be divided into early or rate. Early, which happens within 1 month, there can be hemorrhage or hematoma, can be external cerebral herniation. It can be wound complication, can be CSF leak, postoperative infection, or seizures. Late or delayed are hydrocephalus, subdural hygroma, or syndrome of the Trephind, or sinking flap syndrome. So as I explained you, the CSF related complications are almost 40%. So I'll take and give an example of the first of the CSF related complications. The commonest complication of CSF related is communicating hydrocephalus like this following, this is a case of a unilateral decompressive craniotomy. Patient came back after 1 month with hydrocephalus. This is a patient of bilateral decompressive craniotomy of the frontal region, and he also came with a hydrocephalus, post-traumatic communicating hydrocephalus for after 1 month of surgery. Now, this is a retrospective study of analyzing a systemic analysis of all the published literature on development of post-traumatic hydrocephalus which needed shunt after decompressive craniotomy. Now, there are many papers, there are no, and most of them have encountered from 10 to 40, some of them have 50% needed shunt in their group. So what is the, why there is a difference between some people having 10% hydrocephalus and some people having 50% of the cases of hydrocephalus? What are the causes of hydrocephalus in decompressive craniotomy and how it can be avoided or treated? And not only they develop hydrocephalus, they also can develop subdural effusion also. Like this case, which is treated by Dr. Sweta, he said this patient, after decompressive craniotomy, he developed subdural effusion on one side, and this was the scan. When initially all of us patient comes like this, we'll first treat with a subdural with a burr hole and evacuation, and this was the immediate post-op. But then what happened 1 week? 1 week later, the same patient came with recollection and cerebral herniation. So what is the treatment for this? And the ventricles also were dilated. So what was done was, we did, instead of again doing a burr hole evacuation, what was done was a subduroperitoneal shunt. And following subdural peritoneal shunt, the brain became normal, the ventricle size on the opposite side also came back to normal, and followed this, cranioplasty was performed and the patient did well. This is another case which this patient was admitted for conservative treatment initially. When followed up, the patient worsened, and because of increased mass effect, he underwent a decompressive craniotomy and came back after 1 month with bilateral subdural effusion. Now here, so he's having the experience of earlier, we did not do any subdural burr and tapping of the effusion on both sides. We just placed a subgaleal drain on the right side. When you place the subgaleal drain, one can see here that within 1 week, the opposite side subdural effusion also disappeared and ipsilateral subdural effusion reduced, but the ventricle started dilating. And but then we did a cranioplasty. The patient came back after 10 days later with ventricular dilatation. We just did a drainage LP and patient is doing well. So we could avoid a shunt in this patient. So in addition to bilateral subdural effusions, many patients develop interhemispheric collection also. Now, what is the significance of this interhemispheric collection? Now, all these are a continuum of a problem of CSF absorption. It's only the collection of CSF at different places. They can collect in the subdural effusion, which is an external hydrocephalus. They can collect in the ventricle, it's an internal hydrocephalus, or they can collect in the interhemispheric fissure. It's again a type of. Hello. Yes. Yes. So, you're not connected, sir. Okay, no, this time only is the. I'm just doing that, sir. I'll tell Dr. Varaprasad to connect to you, sir. Yeah, Dr. Varaprasad, hello. Hello. I'll tell Dr. Varaprasad. Okay. Hello, Dr. Varaprasad, you are there? Hello. Hello.
Hello. Hello.
Dr. Mandeshwar called up that he is sharing and we are not connected. Connect him.
Okay, sir.
Yeah. So this collection in the interhemispheric fissure, subdural or intraventricular is a continuing process. So they have a combination of internal and external hydrocephalus. So because there is impaired venous drainage due to damage of the arachnoid granulation. If one does the craniectomy within 2.5 centimeter of the midline, then the arachnoid granulations are damaged, and that causes impaired CSF absorption, and CSF collects in different planes of the brain. In addition, because of the craniectomy, there is loss of pulsatile flow, and because of the adhesions of the basal system, all the CSF circulation is disturbed, and the CSF gets collected in post-traumatic state. So presence of an interhemispheric CSF hygroma is a harbinger that that patient is more likely or prone for post-traumatic hydrocephalus and may need a shunt. This is what the paper published, that if a patient has developed this interhemispheric, then there should be warned that this patient will come back for shunt at a later date. Is there a difference between post-traumatic hydrocephalus between children and adults? All of us might think that it is same, but it is not so. children are more prone for post-traumatic hydrocephalus than adults, and it is probably because they have a higher energy injury than adults, and the higher compliance of brain tissue is higher in them, and because they do not have cerebral atrophy, it's not compensated. So 40% of the need BP shunt following hydrocephalus as compared to 10 to 20% in adults. So how do we reduce the incidence of hydrocephalus in decompressive craniectomy? As I explained you, that one has to avoid the 2.5 centimeter from midline. The craniectomy should not include 2.5 centimeter from midline to preserve the arachnoid granulation, so that a CSF absorption is preserved, and that can significantly reduce the hydrocephalus, as in this case, where we had done a bilateral decompressive craniectomy, and the number of and we had left 5 centimeter in the midline. The other cause of hydrocephalus is infection, and so always before treating assuming that it's a hydrocephalus or CSF absorption abnormality, always it's better to do a contrast scan to look for enhancement of the subdural membrane or ependyma, and this might tell us that it is infection, and first infection has to be treated, followed by the hydrocephalus. The other complications are hematoma or CSF leak. Now, this hematoma has been especially more common in the recent following the COVID state, because many patients, this is an example of a patient, of a COVID patient, which we had done a decompressive craniectomy, and because of COVID status, he was given high dose of low molecular weight, and this patient developed subgaleal hematoma as well as hematoma in the abdominal site also. So both had to be evacuated, and this is the hematoma which is accumulated in the subgaleal space. The third most complication is CSF leak. CSF leak is more common if the incision is 5 centimeter behind the pinna. Then there is vascularity is lost, so that causes wound healing problem and CSF leak. So the way to reduce the incidence of CSF leak is probably to extend the incision in the retroclavicular area and use a pedicle pericranial flap. Like this patient, what we practice is we do a retroauricular incision, and so that the flap has 3 blood supplies, supraorbital, superficial temporal artery, as well as the posterior or the retroauricular artery. So the chances of wound problem is less and wound healing is good. And always harvest a pedicle pericranium like this after reflecting the flap, so that can be, after the hematoma is evacuated, the pedicle pericranium is placed on the dura and hitched or just a onlay graft, so that the post-op CSF leak significantly comes down. The fourth common cause of complication is external cerebral herniation. That is because of inadequate size of the craniectomy. Now, inadequate size is not only harmful for herniation, but it is not helpful for the patient also, because a size of 8 centimeter craniectomy will only increase the total cerebral volume by 1.5%, whereas a size of 12 centimeter will increase the volume by additional 86 ml of additional volume. So compared to 23, it is 86%. So the minimum recommended size is 15 to 12 centimeter rather than just 8 centimeter. If the size of the craniectomy is less, then one can have cerebral herniation and cause complications. The fifth common complication is sinking flap syndrome. The sinking flap syndrome is this an example of a patient where the patient was doing well, but 1 month later he comes with worsening of deficit and worsening of the weakness. So this is because of sinking flap syndrome. Because of the atmospheric pressure on the brain, they worsen in the deficit, and this atmospheric pressure can reduce the cerebral perfusion, and that causes deficit. Hence, it's essential that one does the craniectomy early to prevent the sinking flap syndrome. Though there is a controversy which is the right time, whether it is 1 month, 3 months, or 1 year. But if a patient develops sinking flap syndrome, it is better to do it early. And the sinking flap syndrome is more common if if one waits for more than 1 month. And you can see here, if a patient has the incidence of sinking flash syndrome is 13% within 35 days, whereas it is almost 20% after 35 days. So it is always better to do a cranioplasty earlier or within a 1 month following traumatic injury, brain injury, or as by that time the edema has come down. Not only early cranioplasty prevents the atmospheric pressure on the brain, it also increases the perfusion of the brain. This was a paper which came in 2016 when they did cerebral perfusion studies before and after cranioplasty. They showed that the perfusion increased and the neurocognitive development also was better following cranioplasty. Hence, it's better to do it early. Not only it helps in increasing neurocognitive improvement and cerebral perfusion, but if one does late cranioplasty, there is a chances of bone resorption. And whenever the bone is kept for a longer time, the bone gets absorbed in the subcutaneous plane, and that causes a resorption. So in late cranioplasty, the cosmetic outcome is very poor, like in this case. So the bone resorption rate is very common, is almost to 1 to 17% in this kind of in cranioplasty. And the other complication following cranioplasty is surgical site infection. It's 5 to 12%, which is very high incidence. Now, how do we reduce this surgical site infection and how do you reduce bone resorption, as these are the most two common complications in cranioplasty? And the third most common is hydrocephalus. Now, the hydrocephalus and Triffine syndrome, sinking flash syndrome, can be avoided by doing an early cranioplasty, as in this case, done within 1 month. Now, and this is an autologous bone graft. But then the infection rate in this kind of surgery is almost 5 to 12%, which is quite high. How do you reduce infection in cranioplasty? Is it better to always use an autologous grain graft, the bone graft which is kept in the subcutaneous plane, or it is better to preserve in the freezer and then use it, which has a less rate of infection? Though logically, if you might think that cryopreservation will have a higher rate of infection, but then this paper did not, in 2010, did not find any significant difference between bone flap which was preserved in the subcutaneous plane or cryopreserved. But then later in 2018, where they did a prospective study, they compared which is better, though they found that the division surgery and resorption was higher in cryopreserved one, but they were not statistically significant. So both are equally good. But then there's another paper, they said there's a one precaution that avoid cryopreservation is diabetic patients, as the chances of infection is higher, and do not do a cranioplasty in the preserved one after 1 year, because the chances of infection is higher if the bone flap is preserved for more than 1 year. The chances of absorption also is higher. So if if one is doing a late cranioplasty, it is always better to use an artificial bone or a 3D imprinted bone rather than an autologous bone, whether it is in subcutaneous plane or in the cryopreserved one. So if it's a late cranioplasty, fabricated cyanide titanium is better than an autologous bone. Though we might think that foreign implant will have a higher incidence of infection than using an autologous bone, but this paper where they compared different types of material and analyzing which is better and which material is best in reducing infection. They compared ceramic, titanium mesh, custom-made PMMA, and autogenous bone and PMMA also. And as compared to autogenous bone, titanium mesh had the significant lower rate of graft infection. Hence, if one is planning a delayed cranioplasty, probably titanium mesh is better than doing an autogenous bone. So in conclusion, CSF leak can be reduced by using a retroauricular incision with pericranial flap. Hematoma can be avoided by cautious using low molecular weight heparin, as time goes, more and more COVID patients will come with head injury. And so we have to be very cautious in what dose of local COVID to use heparin for those kind of patients. CSF absorption defects like hydrocephalus or subdural effusion can be avoided if one does a craniectomy within, avoids a craniectomy within 2.5 centimeter of midline. And contralateral subdural effusion and intrahemispheric effusion are indications of post-traumatic hydrocephalus. Always perform a contrast scan before planning a contrast, before planning a shunt, as many of them can have some infection, and exclude infection before placing a shunt. Early cranioplasty is advised to prevent sinking flap syndrome, as sinking flap syndrome is more common when after 35 days of surgery. An adequate craniotomy to prevent external brain herniation. At least minimum 12 to 15 centimeter size of the craniectomy has to be done. And thank you for your attention.
Malleshwara, sir.
Yes, sir. So I cannot hear you, sir.
Malleshwara, sir, you have to unmute.
Yes, yes.
Yes.
Am I audible, sir? Manas?
Yes.
Yes, yes, sir. Now I can hear you.
Oh, okay. You finished your talk or you're starting your talk?
I finished, sir.
But after finishing also, I can talk.
Yes, sir.
A nice talk. And morning we had a paper from my PG on decompressive laminectomy versus open decompressive laminectomy versus this endoscopic.
Yes, sir.
And you have spoken about complications of decompressive craniectomy and complications.
Yes, sir.
Yes. Somehow I missed the contact. So in the last few words I heard. And
yes, I mean that is endoscopic. This was what I spoke was only for head injuries. I did not take stroke, hematoma. Yeah.
Only head injuries you included head injuries.
Yes, sir.
In head injuries also you can use endoscope
for
evacuating the hematomas.
Yeah, but
they will be diffuse.
Yeah, in head injury means many times you do craniotomy for diffuse cerebral edema, and the contusions also are extensive, hemispheric. So only if there is a hematoma, then endoscopy can be done.
Okay. So can I again talk a few words about you before we finish the talk?
Sir, it is already finished, sir. You can ask in the question and start box, sir.
Somebody can question Manas, question and answers. 1 or 2 questions to Dr. Manas.
Sir, Manas sir, this is Dr. BSV Raju.
Yes.
Sir, it's a wonderful talk, sir, as always. Sir, what kind of a shunt do you use for a subduroperitoneal shunt? What kind of a shunt it is?
Yeah, means most of the time this is a low pressure system. Ideally, a programmable shunt is better, but if the patient cannot afford, then a low pressure shunt is advisable.
So, and I don't have much experience in that. What is the success rate, or how often do you need to revise it if it is a low pressure?
Experience means, see, one has to do always like NPH patients in post-traumatic hydrocephalus, before putting a shunt, it's always better to do a trial of drainage LP whether the patient is improving or not.
Okay.
Or a subdural drain. If the patient improves only, then if you do a shunt, then the chances of complications will be less. But many times when you do a drainage LP or put a subclavial drain, they do not improve. So the results are like as good or as bad like NPH in post-traumatic hydrocephalus.
Okay, sir. Thank you. So, in case of post-traumatic hydrocephalus with decompressive craniectomy, if somebody is not able to afford a programmable shunt, how do you manage them?
If they cannot afford a programmable shunt, then I means if you put a low pressure, you cannot change it, is it not? I mean, so it depends. If the patient doesn't have cranioplasty, I use a low pressure. But if patient comes with a hydrocephalus after cranioplasty, I put a medium pressure, and then ask and usually explain the patient to do chamber pumping morning and evening. That works for them.
So you first do a shunt, then followed by cranioplasty. If somebody already has a
Yes. Yeah.
Thank you, sir.
What do you follow?
I had a challenge in some of patients wherein I usually I had done one patient where shunt and as well as cranioplasty I did at the same time. But luckily for me, it is a programmable shunt. So I was always in a dilemma, like, I just wanted those wise words.
Yeah, I try to avoid doing in the same sitting because, as I told you, the need for shunt is very difficult to make out unless they improve with drainage. If you just do a shunt, you'll end up with more complications.
So I always do a programmable shunt followed by cranioplasty. But one patient I tried like this because of some other anesthesia concerns and other things. But I always do but if somebody is not able to afford a programmable shunt, that's a big challenge. It's like Thank you.
Dr. Mohan, what do? You always do a programmable shunt. You have to unmute yourself.
Yeah. We rarely use programmable shunt. Maybe once or twice I've used a programmable shunt. Most often medium pressure depending on the requirement.
Okay.
Okay, Manas.
Yes, I can hear you, sir. Yes, sir.
I congratulate you for your talk and your excellent conducting of this examination online for which is very useful for the DM, MCH and DNB people. And I wish you will become NSA president very soon. That is my blessing because you are younger than me.
Thank you, sir. So we're in time now. We have finished in time.
Some more, if time is there, some more questions. Somebody can ask some more questions. And did you use that so-called bionic implants as cranioplasty in cranioplasty?
Yes, sir.
Bionic 3D implants have you used?
Bionic, no, I not used. We just use the SurgiWare one only.
SurgiWare one.
Yes.
Okay.
Yes.
Okay.
I think the next talk is by Dr. Mohan.
Thank you, Dr. Manas. I missed the first part.
Yes, sir, there's some problem with network, I think. They couldn't connect.
Yeah, you are talking to me, Manas? Anything?
Huh?
I asked something about me?
No, yours is the next talk, no?
No, not mine. Next is Basavaraj.
Next is Raju.
Okay.
Shall we move on to the next? Yes, sir. Please start.
Okay. Thank you, Dr. Manas. Thank you for your nice talk. Thank you, Dr.
Welcome.
Thank you, sir.
Thank
you. Raju, sir, please start your talk.
Can you see, Dr. Varprasad? Can you see the presentation?
Yes, sir. We are able to see.
Yeah, thank you. So, very good afternoon, everyone. Respected chairpersons, teachers, and my dear friends. Firstly, I thank the organizers for giving me this opportunity to share some of my thoughts on fixation in osteoporotic fractures, which is a very common condition all of us will see about. Osteoporotic spinal fractures are often overlooked. They are missed and often leading to painful condition of the spine and disabling deformities. And once they have been missed out, it will be very difficult a challenge to treat them. More so, currently there are no definitive treatment algorithms in the management of osteoporotic spinal fractures. They are further challenged by elderly age of this patient, their comorbidities, high tendency of the instrumentation failure, leading to pull-out, subsidence, and requiring a revision surgery. So the other further challenges are like very times they come in a multiple fractures, sometimes non-contiguous multiple fractures. They require a long surgery and with other challenges with surgeries. So this is one of the things I've taken from the literature. So this very many times they are being elderly, at the same time they require a very long fixation. So how about a short fixation? If you do a short fixation, these things may hold on for a while, but we see like in this patient is a 70-year-old, there's a partial pullout of the proximal screw with the subcutaneous prominence of the screws. The short segment fixation in especially in osteoporotic, there is a chance of failure. So the instrumentation failure can be early or late. These are so it can be very challenging. So the goals of patients with osteoporotic fractures would be you should have a rigid fixation with as many points of anchorage as possible. And you need a good fusion technique of decortication and make them ambulant at the earliest. So that early ambulation only is the only way to treat osteoporosis. And you, in select patients, you may require even a good bone substitutes or even a bone morphogenic BMP also to promote an early fusion in these patients. So there are several biomechanical considerations which you have to understand before you plan for this patient. Pull-out strength is a strength, what is a constant axial force that is applied to dislodge a screw in laboratory conditions. And a pull-out force is a force required to dislodge a screw. Both of these have been significantly reduced in osteoporosis. So with deeper threads or a larger pitch, longer screws, larger screws with biparticle purchase, the pull-out strength can be greatly increased. The maximum insertional torque of the pedicle is correlated with bone BMD. So it's very important that you understand that we have challenges in these patients. So ideally use a multiple points of fixation with the loads applied to the individual screws. The stiffness of the construct is significantly increased. So the most important thing to understand in the success of implant is how we can improve the bone implant surface. That is a fundamental to have a good fixation. How well they can hold on the thing. So it has been found that conical screws are found to be better. The advantage with the conical screw, especially is in osteoporosis, the pull-out strength is much better. But however, if the screw once it is being placed, if you back it out or turn it back, the fixation ability will be lost. So expandable screws have been reported since early to last few decades, and they've been found to have a wonderful kind of a pull-out strength in these patients. And the big challenge in this patient is osteoporosis is because of the limited strength of the bone and the bone implant interface. The anchors may not be able to allow strong compression, distraction, or rotations once it is in place to correct a deformity. So to aid it, different kinds of cement can be useful to improve the pull-out strength of these patients. So when do you need surgery in osteoporosis? Because very many times once they have been detected early, you can possibly treat them with medical means in more than 95% of the patients. However, when somebody has a severe osteoporosis, somebody has a severe unstable fracture, severe compression burst fracture, neurological deficits, already a failed vertebroplasty or kyphoplasty, they may need surgery. Sometimes a patient may not like to have a limited kind of a mobility for few months that can be used about. The important thing, however, to understand for an indication for surgery is the spinal instability. The spinal instability in the sense somebody who has a persistent back pain or a deformity, these people may suggest a spinal instability. Together with extent of bone destruction or ligamentous injury on imaging can roughly can give us about an indication which patient may require surgery. So there are several techniques how we can improve the fixation by screw design, insertional technique, and other means. The most important is an insertional technique what we use in this patient. You make a, so the important is a screw design. So then compared to a normal standard screw, if it's a conical screw, it is found to have a better kind of a pull-out strength. And off late, even the Medtronic and other companies have come out with the double screws, which has a normal screw, which is with the cancellous bone, whereas the pedicle part of it, you have a different kind of a threading. It is found to have a better kind of a pull-out strength. Cannulated screw, which has been hollow inside with the holes inside of the proximal part of it, it can help us to have a cementing of the bone, is found to be very useful. Hydroxyapatite coated screws, they have a better biological integration with the bone matrix, with the screw matrix, have been found to be useful. Expandable screws have been mostly been tried in Europe and some parts of the US. They have been all again found to be very useful. So how do you basically improve your fixation techniques? The best thing is you have a under tap the thing or don't tap the osteoporotic bone. Even if you tap it with a undersized tap, maybe holding on for for a couple of turns or at the max a centimeter or so that the pull-out strength of the screw can be quite high. So when the screw orientation is tried to be like a triangulation, it has been found that whenever there is a triangulation with a medial orientation, the medial part of the bone between the screws is found to increase the pull-out strength. And similarly, compared to a normal parallel orientation or a caudal orientation, cranial orientation of the screws avoid an increased bending arm of these portions and ultimately found to be more useful. So whenever I basically use a small bone awl at these patients to start with, and if possible, whenever you use it, don't need to tap even the entire part of the bone. Even when you use the bone awl, you try to use only the bone awl only up to the posterior part of the bone. Then rest of the thing you can directly start screwing it, because these patients have bone is very, very soft. And compared to the convention, don't try to avoid hubbing of the screw head or the entry point. And very often I try to use a cross link with the construct is been especially longer, and always can use a osteoconductive material like a tricalcium phosphate, or even sometimes to aid the fusion with a BMP. So the best point of insertion has been found by Raikemel is the junction where the superior articular facet, the pars interarticularis and the transverse process meet. There is the strongest point that is being called as a force nucleus. This is the best point, especially can be marked out in all lumbar spines. It is the best point for best biomechanical strength. So these surgical techniques are basically posterior techniques, and there are different techniques, whether you use a short segment where is one segment above and below the fracture, or long segment, two or more segments above the fracture, maybe with the cement augmentation with the PMPA or a calcium phosphate. And it may also require a fixation of the fractured vertebrae for better correction of the deformity or expandable screws. However, the same techniques can be done even with a percutaneous fixation with or without polymethyl methacrylate augmentation. So anterior fixation and decompression have been tried, and sometimes, especially in the severe fractures with instability, combined techniques, anterior and posterior with osteotomy, or with a percutaneous procedure like vertebroplasty and kyphoplasty has been found to be useful. So by gold standard, most patients, especially is unstable, they require a long segment fixation, especially in the presence of deformity. They can have a better correction of the deformities, and crosslinks can be very useful to prevent the rotational forces and implant failure. So this is one of my patients who had a quadriparesis with a T12 fracture, and he has an excellent relief, excellent improvement of the neurological status, including bowel bladder symptoms. Another of this patient has a multiple contiguous fractures, and they had a long segment fixation with an excellent results. And preoperative CT can be very, very useful to understand and estimate the possible length of the screw. However, no attempt should be made to have a bicortical purchase in these patients. So in some elderly patients, even you can try this long segment fixation along with the bone cementing, and so that the pull-out strength is being improved and there's a less chance of instrumentation failure. And same thing can even do with the hydroxy-coated screws, which have been useful. And very many times these patients, they require, because associated with neurological deficit, they require a coexistent decompression. So whether it is when somebody has a does not have a gross compression or something, a simple percutaneous technique, short segment fixation can be useful. And this patient, as preferred as a policeman, does not want to hold for a long time, and with the multiple comorbidities like diabetes, hypertension, and other things, and we can do this procedure with a short period of recovery. So short segment fixation has been found by several studies to be useful, can be comfortably done. As Lu et al. Has shown in 46 patients with a follow-up of around 20 months, it's been safe and efficacious with no instrumentation failure. And even in patients who have a thoracolumbar fracture with neurological deficit, few studies have shown that this is one study by Cheng et al. With 20 patients with a follow-up of 40 months, though major ligamentous disruptions or major dislocations have been excluded, in this patient, a short segment fixation has found to be very helpful. However, if you see in patients who have a low lumbar or lumbar fractures, the complication rate is quite high compared to thoracic fractures because the support of the thoracic cage is being lost. And in this study with around 38 patients, Kohana et al. Have found an instrumentation failure of 37% and a vertebral collapse of 27% in a follow-up of 3 months. All these patients in the lumbar fractures are presented with radiculopathy. So, however, these patients ideally require a good augmentation technique, so that because the loads in the lumbar spine are quite different and otherwise compared to the thoracic spine. So, how about a meta-analysis of systemic review have shown out of 1,831 studies, 32 are found to be eligible, and 19 have presented a screw loosening rate in patients with osteoporotic fractures. It has been found that screw loosening is around 22.5% in augmented screws and 2.2 with augmented screws with cement. So it's like it tells about grossly that the complication rate or instrumentation failure is almost 1 in 5 patients can have a failure of the construct. So screw augmentation could be very useful, and a repeat surgery, a revision surgery is very, very challenging in these patients. So, however, some patients, when are the chances that a short segment fixation can fail? It has been found is one of the only literature that has been reported by Formica et al. They tried to study what are the risk factors for local kyphosis and a failure of a short segment fixation. They found that the smoking habit, sex, age, neurological status are not related to loss of correction or the screw failure. And they found that obese patients with BMI more than 30 has found to have a high risk of local kyphotic collapse after short segment fixation. So it's better especially in obese patient to have a long segment fixations. Short segment fixation can be combined sometimes even with a vertebroplasty like in this patient. Sometimes you can even combine this with vertebroplasty and cemented screws. The short segments, the literature wise, it has been shown that a short segment fixation, when combined with kyphoplasty or vertebroplasty, has found to have a significant success rates. As studied by Korovisi et al., they found in 21 patients the follow-up of 1 year, they've reported no instrumentation failure and a better correction of the kyphosis. So this is one of the patients I got it from the literature, a short segment fixation with augmented screws and fixation of the fracture vertebrae with vertebroplasty. This basically greatly improves the construct of the thing and avoid a long segment fixation. And this may be the way to go, especially in patients who have a high risk, so that it shortens the time of surgery. So this is another patient, the short segment fixation with cement augmentation. So how is the results in the cement augmentation of the pedicle screw has been found to be very, very uniformly successful. Girde et al. They found in 52 patients in the follow-up of around 4 years, there is no patient of screw loosening in PMPA augmented screws. So how do you compare the biomechanical strength of commonly used cements like polymethyl methacrylate compared with the calcium phosphate cement? Calcium phosphate cement is biological, biodegradable, osteoconductive, and does not actually give any exothermic reaction at the time of delivery. So hence, the biological cements like calcium phosphate, calcium triphosphate, hydroxyapatite phosphate cements have been increasingly tried. The biomechanical strength of a PMPA screw, of a calcium phosphate screw, is comparatively around 100 times more, 100% more than the normal screw. However, the augmented screw with PMPA has found to have 147% more than the normal screw. So both calcium phosphate augmented and PMPA augmented screws have a significant improvement in the pull-out strength of the screws. So, however, whenever you try to use a cement, the main concern that basically is whether the cement can leak. The leakage can be into the local area, into the discal area, into the spinal canal, or commonly into the perivertebral area, and sometimes it can embolize into the pulmonary system. So this is one of the early studies. They have studied with a CT scan of the local part and the X-rays of the chest in 98 patients of around 474 screws. They found that the leakage of the cement is seen in around 94% of the patients. So it's very common, but none of these things are significant. And in 4 people, there is an asymptomatic pulmonary cement emboli has been seen. So while the cement leakage is very common, this very often is not symptomatic or has any kind of a sequelae in this patient. So it is very safe. However, the best way to reduce the cement leakage is to deliver the cement whenever this cement is being delivered under a continuous fluoro. Especially this is required to avoid any kind of a high volume leakages that can cause, can be of any consequences. So other alternative, if you really want to avoid a cement, would be expandable screws. So in another study, Pinera et al. They found that PMPA augmented screws in a prospective study in patients over 70 years, they found it to be very useful. In 23 patients, in a follow-up of around 20 to 49 months, they found no instrumentation failure. However, as reported in some other studies, 3 of these patients have a deep-seated infections. So infection is a concern. It's been reported in several other studies, both in orthopedic and as well as in spine surgery, that PMPA cement can have chances of a deep-seated infection. However, the other risk in the patients with PMPA polymethyl methacrylate augmented screws is revision of the surgery can be very, very challenging in these patients. To avoid all this, there's a concept of the development of hydroxyapatite, which is a basic ingredient of the bone. Augmented screws have been started for the osteoporotic fractures, both in extremities and as well as in the spine. So the advantage of hydroxyapatite is an osteoconductive material, is a bioabsorbable. There is a better and early integration of screw bone matrix into the integration of the screw into the surrounding bone matrix. In a 34 patients, they found that none of the patients have any kind of a instrumentation failure by Zhang et al. It is all 34 patients underwent surgery involving the lumbar spine. They try to understand not only just about the instrumentation failure, but also about the screw angle. They found that there's less chances of angular displacement of the screw, less chances of subsidence when used along with interbody fusion, and there's less loss of lumbar lordosis. So hydroxyapetated screws have been found to be very useful in these patients. And biomechanically, the screws are being found to have a strength of around 100% more than a conventional pedicle screw at 12 months. So this is the advantage of a hydroxyapetated screws. They are biologically compatible, biodegradable, osteoconductive, and the matrix at the bone screw has been replaced. Is been very well replaces the normal fibrous membrane that forms around the bone and the implant. So by micro CT analysis, they have found that the normal average contact area of the screw is around 57% in a normal screw, and compared to 96.6% with hydroxy-coated screws. And further, when they try to remove a hydroxyapatite coated screw, we find that very many times the hydroxyapatite coating is also being integrated into the normal bone. It tells that there's a better integration of the screw bone matrix with hydroxyapatite coated screws. And the revision of these patients is much easier compared to a patient who had a cement augmented screws. So biomechanically, how do you compare different kinds of cements that have been techniques, augmented screws technique between a bone cement, hydroxyapatite coated screws, calcium phosphate augmented screws? It has been found that hydroxyapatite coated screws are possibly, when compared with axial pullout strength. Axial pullout strength is the load required when an axial force is constantly applied to the vertebrae, the load at which the failure occurs. So that is the axial pullout strength. The axial pullout strength of hydroxyapatite coated screws is comparable to that of a calcium phosphate screws. However, PMPA is found to be 60%, strength of PMPA is around 60% more than the normal conventional pedicle screw fixation. So the best strength is by polymethacrylate cemented screws, and compared and followed by that of a calcium phosphate augmented screw or a hydroxyapatite screws. So how do you make, this is another study by Kashi et al., where they try to review for the first time in the literature, because whenever you talk about a posterior surgery, the decompression of the neural structure is an indirect decompression. However, some people have a severe deficits, including gallbladder involvement. And is there any role when you try to do these patients differently with anterior surgery, and somebody has a severe deformity because you don't want to have a maximal corrective forces? Is there any role for posterior surgery with osteotomy compared with the posterior spinal fusion techniques? The three techniques: anterior surgery, posterior surgery with osteotomy, and posterior spinal fusion with decompression, have been studied for the first time in the literature by Kashi et al. In 2013 in 88 patients. They found that there is no significant neurological difference in all three groups. So it basically tells that direct neural decompression is not required in patients with osteoporotic fractures, osteoporotic fractures of the lumbar spine. So indirect decompression by means of posterior surgery is supposed to be useful. However, people who have an osteotomy have found to have a significant blood loss. So the best minimally invasive option would be a posterior spinal fusion with decompression if combined with a vertebroplasty is the least invasive procedure for this patient. So anterior surgery does not have a great role in patients with osteoporotic lumbar fractures with neurological deficits. Expandable screws have been in vogue for over the last couple of decades. However, their use has been limited mostly to some parts of Europe. There's been in this one study with 16 patients with more than around 76 years of mean age of unstable thoracolumbar fractures. They found no intraoperative fractures, and they found no instrumentation failure by Isher et al. So another study of 2-year follow-up by Gazzeri et al., they found in 31 patients with a mean age of 61 patients, 2 patients have required a revision at 2 years. So, however, they felt that the results has been comparable to that of a cement augmented screws. However, in the disaster results with cement extravasation can be useful. So this is one example wherein a short segment expandable screws with a local support expandable bone thumb has been used with a good success. So, however, to improve further the construct, expandable screws have been used with cement augmentation. This is the first study wherein Yu et al. Have been combined the expandable screws with cement augmentation. They found that in cement augmented expandable screws have the highest amount of maximum pull-out strength compared to of around 59% over the normal screws, and is quite higher than the normal expandable screws are a segment augmented pedicle screws. So to conclude, the right selection of the screw design and the technique has been very important for success of this patient. And newer screw designs are techniques like hydroxy-coated screws, cemented screws, expandable screws have greatly improved the success in these patients. And minimally invasive techniques can be used with less surgical risk, especially somebody has a lot of surgical risk, it can reduce the amount of surgical time. So with further developments of the biologics and better understanding of the biomechanical properties of implants, hopefully in future we can further reduce the instrumentation failure in these patients. Thank you.
Hello.
Hello, sir. Yeah.
Sir, Sridhar sir.
Yes, sir. Hello.
Yeah.
Hello.
Please, you are the chairperson, sir, for this session.
Sir, very good lecture anyway, but I'm not getting this.
Am I audible to you?
Yes, sir.
Yes. Sir, I'm not getting camera to my side. I don't know why.
Is it?
I think Dr. Sheshadri Shekhar has to unmute himself.
Unmute,
Yes, sir.
He's
I
not
unmuted
unmuted.
now.
Yeah.
Yes.
I got it now. I'm audible now, sir.
Yes, I'm able to hear you. Well, yeah.
It's a very nice lecture anyway, but
thank you.
Sir, how do you select cases for surgery?
As I told you,
surgery is the only option you have, but
yeah,
kyphoplasty.
Surgery, as I told you, surgery is basically required in patients who have a neurological deficit.
Okay.
Somebody has a persistent pain following a percutaneous procedure like the vertebroplasty or a kyphoplasty. And some people, they have a persistent pain which has been there even after the conservative treatment, that tells that there is a significant spinal instability. And in this patient, we may need to correlate again with the radiological kind of evaluation to understand whether there is any kind of a coexisting ligamentous injuries or any kind of extent of how many columns of bone have been injured, whether there is a 1 column, 2 column, or a 3 column injury, whether there is instability in the form of or a spondylolisthesis coexisting, because these patients very many times are elderly. They have a coexistent degenerative kind of instabilities also, especially with trauma. They can have a associated ligamentous injuries. So if somebody has a deficit, instability, gross instability radiologically, or a dislocation, they ultimately directly go for surgery. But some people, they may fail after conservative treatment, they may also end up in surgery. Some people, by preference, they want to have a quality life from the day one, because the aim of the surgery is to ambulate them in the next few days after the surgery.
Next thing is, basically they're all metabolic. Majority of them are metabolic.
Yeah.
So how do you work up the case?
So all patients, my patients, basically I do a BMD for all those patients. Whenever there is a suspected metabolic issue, I basically refer it to a physician to have a further workup. Otherwise, all these patients, when the BMD is low, they basically will be put on teriparatide. So if somebody has a very severe deficit or some, then only we'll try to operate immediately for a deficit. Otherwise, we'll hold for 3 to 6 months, improve their nutritional bone health, and then take up for surgery.
Is there any experience of bone morphogenic proteins?
I have used it some time back, not recently, over the last 3-4 years, and I have a lot of experience during my stay in US. It definitely works wonders.
Is it DMP 2 and 7 or any other variant?
Yeah, so of late I have not used it. I used once around maybe 10 years back or so. I used once with the Medtronic people. Of last 10 years, I have not used it. In US, it has been used very frequently. Even for a conventional, whenever you think that somebody has a high chance of non-fusion, let's suppose a smoker having other issues like osteoporosis, wherein you want an early kind of a fusion, they try to use it. Sometimes it is off-label use of BMP is also being used, especially abroad.
Thank you very much, sir. Thank you, nice lecture.
Thank you, thank you.
Very useful for the PGs.
Thank you, Dr. Raju. Excellent lecture.
Thank you.
What else next? Next speaker, Dr. B.S. Mohan, I think.
If there are no more questions, I thank you all for giving me this opportunity.
No.
Yeah, thank you, sir.
For the participants, they can ask questions.
Okay, yeah, that's like, yeah.
Let's move on to the next lecture, sir. I think there are no more questions, I think.
Okay, thank you. Thank you, Dr. Shekhar and
Yes,
Ashtinas. Yeah.
Can I start my talk?
Yes, sir. You can proceed, sir. You are welcome.
Can you see me? Can I see my slides?
Yes, sir. Yeah, we can see you, sir. We can hear you.
My slides are being seen?
Yes, sir.
Thank you. At the outset, I would like to thank the organizers for giving me this opportunity to present my topic. And today's my topic is management of intracranial hemorrhages in patients with anticoagulants and antiplatelet drugs. In the present day, most common drugs which are being used by almost everybody are antihypertensives, anti-diabetic, antiplatelet drugs, and statins. As our care hospital is famous for cardiac services, we get to see a lot of patients on using antiplatelet drugs and anticoagulants. All age groups of patients undergo cardiac surgeries in our hospital. Either they have mechanical valves and anticoagulation is a must for them. Ischemic heart disease and stroke prevention for most of them are put on antiplatelet drugs. Though biological valves do not require anticoagulation, arrhythmias and pacemaker necessitate their usage. These complications come back to us, so we have to deal with them. So most often these patients, they come back to us and we treat their complications. So those patients come to the cardiologist and cardiologists in turn refer to us. It's not moving. What are the issues in these patients? Expanding hematoma is a very common thing. The patient comes with a small hematoma. Within few hours, the hematoma will be expanded. Reversal of these drugs, how to do and how much to be given. When to restart, when you suspect a recurrent hematoma, a thrombotic event which is there has to be addressed, and other complications, if there are any, has to be addressed. If the patient is a diabetic, these days is a very common practice. A patient goes to a physician, patient is a diabetic and hypertensive, even if he's less than 40 years old. If he has a slight increase in cholesterol, he's put on antiplatelet drugs. If the patient complains of slight giddiness and he goes to a doctor, he's put on antiplatelet drugs. Such patients who are very young, they are prone for injuries in their day-to-day activities and also in the road traffic accidents. So we have to be very cautious in starting the patients on antiplatelet drugs and tell them, educate them to tell their doctors if they have any problems, any surgical interventions if they have to undergo. They have to tell their doctors that they are being on these particular drugs. So the risk of intraoperative bleeding and postoperative recollection of hematoma is a major the thrombotic event causing so it has to be tailored to the needs of the patient. And hello, am I audible?
Okay, sir, you carry on, sir. Is audible now.
Okay, sorry. So it has to be tailored according to the need of each individual patient, how these drugs have to be reversed and when to restart them safely depending on their underlying condition for which these drugs are started, and how safely we can restart without causing a risk of a rebleed. Some patients can be both on anticoagulants and antiplatelet drugs who carries the maximum risk of expansion of the hematoma and having a thrombotic event if they are stopped. The consent and prognosis. What happens these days when we see patients, patient relatives expect 100% guarantee that the patient should come back home and he should not have any problem, which is not possible in such situations. Explain clearly what happens if he is not operated. Explains what can happen when they are operated. Explain about the poor prognosis regarding mortality and morbidity. Patient can die. Even patient can die on the table. Patient can have morbidity like a hemiplegia. These things have to be explained. Complications like a thrombotic event. The patient relatives don't care whether he died because of surgery or because of a stuck cardiac valve. They blame the surgeon who has done the particular surgery on the particular day. So general complications of patients in an unconscious state are very, very important. Explain to them about the ventilator and ventilator-related infections, etc. All these things have to be explained to the patient relatives before you take the patient. So types of hemorrhage, it could be spontaneous, maybe because of hypertension, they can have a spontaneous hemorrhage, or because of overdosage of these anticoagulant drugs, or wrong usage, they can have a intracranial hemorrhage. It could be a traumatic hemorrhage, or it could be iatrogenic. These days, thrombolytic agents were using quite often, both in cardiac as in ischemic strokes. But today, that is not the topic of the day. We'll discuss in the later. In the location of hematoma, the location could be anywhere. It could be extradural, it could be subdural, it could be intracerebral, ventricular, or subarachnoid. Wherever, at all planes, you can have hematomas in these patients. What is the common problem? The patients on anticoagulants after a certain period of usage, they take it for granted. They stop getting their PT, INR levels being checked. They stop coming to the hospital, but one fine day they'll be found unconscious and they'll be brought to the hospital. They consume food which were told to them not to consume, like green leafy vegetables, tomatoes, other things, but they consume them and their anticoagulation goes haywire and they'll be again brought to an unconscious state. Some patients are erratic and they don't take their antihypertensive medication, because of which they'll have a high blood pressure and have a bleed at the time. They can have comorbidities because most of these patients with hypertension can have a renal problem, or in addition can have a liver problem, because most often they are also on alcohol abuse. So such patients can have other problems as well. So staying alone, some patients these days, we find them most often they're staying alone or in old age homes. Others will not know what medications they are on. So when they're brought to the casualty, we have to make sure that these medications, what they are taking, we have to really look for the prescriptions or older charts and then know what exactly they are on. What do we do? Whenever a case comes to the emergency, with or without history of trauma, we get in addition ask for PT, APTT, and INR and platelet count. Repeat a CT scan. If the scan is done elsewhere for more than 6 hours back, it has to be repeated again. In addition, if the history is available regarding comorbidities, LFT and renal parameters are checked. ECG and 2D echo is a must for all these patients. When should we be cautious? Most often in the middle of the night, we get a call from the casualty that's saying that there's a patient with a small intracranial bleed. The pill will be sent on WhatsApp. There's no history. The duty doctor just gives the call and says, Jesus is 15 people are normal, sir. What should I do? Because there's no history, we have not seen the patient in the middle of the night. They say, okay, manage conservative. Within the next 3 hours, we get a call from the hospital saying that the patient is decelerating and having a fixed dilatation. Here we have to be extremely cautious. Insist your duty doctor to take the history of any of these drugs being used or not. If they are being used, they have to extract. Any older age group patient with a scalp hematoma and ecchymosis over the body or on the face, we think of suspect of these drugs being used and get an investigation done without fail and also admit them. All patients with history of antiplatelet, anticoagulant drugs, even if the CT scan is normal, needs to be observed for minimum 24 hours. If not, do a CT scan again within 6 hours and the GCS continues to be 15 by 15. These patients can be discharged safely. What are the role of serial scans? Most often patient relatives suspect us. They say the minute we got one CT scan done, again you wanted to done in your hospital, explain to them what is very, very important because these hematomas can expand. Patient on these drugs, the hematomas expand within a period of 3 to 4 hours. Also, we sometimes see the hematoma expanding. So all patients, whether either with a small or no hematoma, in any of the planes, a repeat CT scan is a must. If there is a decrease in level of sensorium, if they have comorbidities, if there's a fracture of the skull, these patients should be re-investigated with a CT scan. 6 to 12 hours after the first scan, look for an expanding hematoma. It can be even at earlier than 6 hours also. If the INR is very high, even the hematoma can expand in a much earlier time itself. What are the high risk for thrombogenesis? Some patients are really high risk. Some people are just like that are started on anticoagulants or antiplatelet drugs. However, there are certain group of patients which require definitely anticoagulants and antiplatelet drugs. Which are this group of patients? Patient with mechanical valves. Sometimes there will be two valves which change both mitral and aortic. Such patients definitely needs anticoagulants. Pneumatic heart disease, atrial fibrillation, left atrial thrombosis, left atrial assist device, stroke within last 3 months with or without atrial fibrillation, active cancer in the body, venous thromboembolic phenomenon within last 6 months, or with severe thrombophilia. These patients need to be on antithrombotic agents. Lupus, antithrombin 3 deficiency, all these cases require pre and post-operative bridging with heparin or low molecular with heparin. Before and after the surgery, these things are must. For an elective surgery, bridging has to be done. Stop the anticoagulants and antiplatelet drugs. Do a bridging with low molecular weight or heparin. Stop them before 12 hours before surgery in an elective condition or in an emergency condition. We have to reverse the drugs and then again at the just restart the drug. We have to do a bridging with a low molecular weight heparin or heparin. What are the routine tests which are done for the coagulation? Earlier days, all surgeries were being done with bleeding time and clotting time. But however, bleeding time and clotting time are found to be not relevant for any of these bleeding disorders. So they are not routinely being practiced because they are individual dependent and cannot be standardized. Prothrombin time is the one which is done routinely for extrinsic pathway. Activated partial thromboplastin time or APTT is done for both direct and common pathways. Thrombin time is done for fibrinogen deficiency or heparin is being used, and serum fibrinogen levels are also checked. And international normalized ratio or INR, which is routinely called, has to be done as a routine coagulation test. And we get mostly PT, APTT, INR in emergency settings. So special coagulation studies. So these are just to mention, most of them are not available routinely in most of the hospitals and they're not being routinely be done. But we know what are the tests which should be available. One is platelet aggregation test is one important if there are antiplatelet drugs. Assay for factor inhibitors, factor activity assays involved. Already patient has been diagnosed with a 1 milligram disease. The tests which are required for that particular disease have to be done. Lupus antigen testing, example, dilute Russell Viper venum time. All these things are to be done in case we know what exactly is the patient having prior to taking him for any of the elective or emergency surgical procedure. So what are the types of antiplatelet drugs? As you all know, we routinely use only aspirin and clopidogrel, but to complete, there are also so many other newer drugs which are available: clopidogrel, prasugrel, ticlopidine, ticagrelor, pancrelar. All these things are available in the markets. Some of the cardiologists use the common ones are aspirin and clopidogrel. So types of anticoagulant drugs. Routine drugs which are routinely used are anti-vitamin K antagonist or which are warfarin, acetron. In most of the patients, these drugs are being used, especially in the cardiology. In a patient in a valve replacement setting, warfarin and acetrom are the commonly used drug at a dose of 1, 2, or 3 milligrams, depending on their INR. Generally, they want the patients to be INR should be minimum between 2 and 2.5. So for them, the best drugs for them is acetrom and warfarin, which is used. And how do you monitor them? You have to do a PT and INR. And if you want to anatogenize that particular drug, we can use vitamin K, FFP, or PCC. So again, unfractionated heparin for so many conditions we use, or during studies, heparin also being used. It has to be given parenteral. APTT has to be monitored. Protein sulfate is the antagonist for it. And if there is a low molecular weight heparin which have been used, and they are deltaparin, enoxaparin, tizaparin, all are given parenterally, and all can be reversed by giving protein. And anti-10 condaxparin is parenteral, rivaroxaban, apixaban. These are the drugs which are being routinely used now during the COVID period. Most patients are put on oral anticoagulants. These are the drugs which are being used, and they can be only reversible factor, 4-factor PCC. If not, they have to give them only FFPs have to be given to this patient. Direct thrombin inhibitors. Dabigatran is oral. It can be reversed by idarosizumab or 4-factor PCSK9, and other drugs are also there mentioned. So this is the, as you all know about the clotting mechanism and the coagulation, which we have studied during our physiology days. This is a common pathway which has been used. After the platelet aggregation, coagulation pathway comes into effect. So there are various studies have shown how to use, how to reverse. This is one of very good paper in Neurology India from NIMHANS as well as from St. John's Medical College. This is one paper which has given extensively about how to reverse these things, and also the other papers which have studied how to reverse the particular thing. But all these papers are whatever said and done, all these have to be done individually for individual patients. Another important thing, steps in the management are always involve your cardiology colleague, so that an urgent ECG and 2D echo has to be done to know his cardiac status before surgery. Some patients could be in cardiac failure state. Unless you know prior to it, if you overload the patient, these patients can die. So you have to involve your cardiologist all through the during the treatment. All the cardiologists should be involved. This gives an information regarding the cardiac valve status, if any, and any aerodynamic signals in the heart. These are present. When to restart the this anticoagulants, you can always do it in consultation with the cardiologist and an anesthetist. Free of anesthetic check is mandated. Control of hypertension is very important. Sometimes if the patient has so many comorbidities, the anesthetist might give GA. Sometimes we may have to even do conditions. Local anesthesia, we may have to operate. In such high risk cases, informed consent and video consent, as I mentioned earlier, is very important, because these days the patient dies, all the patient relatives make a big ruckus in the hospital. We have to tell them about the death and their disability before you take the patient to theatre. General principles of reversal. So, how do we reverse these drugs? This is what is important before you take the patient to surgery. So, in any elective surgery, stop anticoagulants 5 days prior to surgery. Some say 5 days, some say 7 days. Best is to wait for 7 days of anticoagulants and then take the patient to surgery. But if it's a high risk case, you may have to do a bridging, as I mentioned earlier, with low molecular weight heparin, which can be stopped 12 hours prior to surgery. In antiplatelet drugs, aspirin can be stopped for 5 days and clopidogrel can be stopped for 7 days, and you can safely take the patient for surgery. But in emergency situations, these drugs also have to be reversed. Control hypertension around 150 millimeters of mercury before surgery is also mandated. So the antiplatelet drugs, how to reverse them? Only aspirin. Some studies says no need for transfusion of platelet if the platelet count is normal. However, it is safe to give transfused platelets before surgery, because sometimes we feel right from the time you mark the incision on the scalp with a needle, the scalp keep on oozing. It will be definitely more than the normal. Such patient definitely, unless you give them platelet transfusion during surgery, you will find very difficult to control the bleeding. On dual antiplatelet drugs like aspirin and clopidogrel, some studies suggest also no transfusion. However, it is very, very difficult to accept These patients definitely require intraoperative hemostasis. For them, we need to give them transfusion with either a single donor platelets or 4 to 6 pooled platelets 3 hours prior to surgery. This is very, very important. Sometimes when you give a platelet transfusion, the platelets should have been given overnight and then you take the patient for surgery in the morning. It is not correct. Once the platelets are given, these platelets can be deactivated by the already existing antiplatelet drugs. So just 3 hours prior to surgery, you have to give them transfusion. And during surgery also, this transfusion has to be given. At times, even 10 units of multi-donor platelets may be required. And if you want to potentiate the platelets, DDVP can be given at a dose of 0.3 micrograms per kg can be given. This potentiate platelet aggregation. This is available and it can be given. The bleeding is not getting controlled. Activated factor 7 can be given, but sometimes it will be available, sometimes it is not available. General principles for reversal of anticoagulation. How do you reverse anticoagulants? So for antivitamin K agents, warfarin and acetron, IV vitamin K is the drug of choice. It has to be given for a minimum of 3 to 4 days. Given. After the during surgery and after pre-operative and post-operative, it can be given. Fresh frozen plasma can be given. 3-factor or 4-factor prothrombin complex concentrate can be given. What do they contain? Factor 2, 9, 10, and 7 are available. Then sometimes in 3-factor, 7 is not available. So most often in neurosurgical cases, 4-factor PCC is what is routinely recommended. PCC has got 4 times faster action than FFPs. So, but for novel anticoagulants, what are the drugs which are, as I mentioned earlier, ridaroximab for Decapeptyl or hemodialysis has to be done. If the patient has consumed the drug just 2 hours prior to surgery, activated charcoal can be given to prevent adsorption. And adenoxate alpha can be given for rivaroxaban and apixaban. And FFPs can also be co-administered for these drugs. Monitor the INR to bring it down to 1.5 before surgery. So unfractionated heparin can be reversed by protamine at a dose of 1 milligram for 100 units. Low molecular weight heparin are resistant to protamine. Only 50% reversible is possible for these drugs. So sometimes you may have to give them FFPs also. And also if the PCC are available, 10 ml of PCC is equal to 600 ml of FFPs. So if the patient is going to have an overload because of FFPs, the PCCs can be given safely, and that even sometimes if that can even result in a thrombotic event. So we have to be very careful when giving a PCC and FFPs. So in either PCC or 4 PCC are not available, how do you manage this patient? First, start with 2 units of FFP by rapid infusion. Check INR after 15 minutes. If the INR is still above 1.5, repeat 2 more units. Add loop diuretic if you think there is an overload is a concern. The number of units depends on the INR at the start. So all the things have been added some 6 or 7. And at that times you have to give vitamin. All these things have to be given along with the claim intimation. Dose of 10 IV or and not only stop these drugs or reverse these drugs, at the same time we have to reinstitute these drugs so that they don't get a thrombotic events. So in a low risk patient, how do you restart the drugs? Antiplatelet drugs can be started. Repeat a CT scan post-op after 24 hours. Some say you can restart the drug within 48 hours. But the anticoagulants, you can repeat a CT scan if there is no hematoma, restart with low molecular weight heparin after 72 hours, and then convert it to warfarin. High risk thrombotic events, the patient, as I mentioned earlier in the group, if the patient has got high risk for thrombotic events, antiplatelet drugs can be given 6 hours after a 6 hour post-op CT scan. If there is no clot, you can restart them after 12 hours, start low dose aspirin. Anticoagulants after 6 hours post-op, if there is no clot, restart with low molecular weight heparin and convert to warfarin. This is what's called bridging. Recheck the CT scan as and when required, and in case of any deterioration, repeat a scan immediately. In patients with mechanical heart valves, always advised to get a 2D echo as and when required to see the status of the valve. Whatever you have done a major surgery, craniotomy, and if the patient dies of a stuck valve, still you will be blamed for the surgery which you have done. So it's always better to involve everybody and tell them this is what you have to do. No, and now coming to the individual hematoma areas, hematomas, extradural hematoma, it can be seen in both groups of patients, either on antiplatelet drugs or anticoagulants, and it mostly seen post-trauma. It can also happen in some patients on anticoagulant, but most common problem is trauma is involved. Hematoma expansion is very fast in patients on anticoagulants. Within 1 hour to 2 hours, you may have a large hematoma in these patients. Intraoperative ooze is a problem in patients on antiplatelet drugs. Craniotomy can be done only after reversal and platelet transfusion has to be given to these patients. Evacuation of clot should be complete. Adequate hemostasis have to be achieved and heat stitches have to be placed. Leave a subgaleal drain close to the burrhole site so that if there is any recollection there, it can be sucked out with a closed suction drain. A repeat CT brain can be done, and before discharging, definitely a scan has to be done and restart the anticoagulation antiplatelet drugs. Watch for 2 days and then send the patient home, but ask them to come for review within a week's time. Acute subdural hematoma always requires an emergency craniotomy. In case the brain edema is very severe, it has to be combined like a decompressive craniotomy, and this has to be done only after adequate reversal. Again, repeat CT scan after 12 hours, or in case of any pupillary changes or worsening sensorium, do a repeat scan immediately. Always leave a subgaleal drain in these patients also. Some can have an addition to contusion, which can have which can expand and may require evacuation again. I'll show you an example of what we've done very recently. So this patient came with patient with GCS was 15/15. He came with an acute subdural hematoma with mild weakness in one side. So we did a scan. After that, we took him for, we did the reversal and took him for surgery. We did a craniotomy and evacuated the clot. If you notice, there's a small temporal contusion there. There's a small temporal contusion, and within the next 1 day, the second post-op day was fully alert. By night, he became drowsy. When we repeated a scan, there's a large temporal hematoma. So again, we took the patient for surgery and we did a small temporal craniectomy. The top, you can see the craniotomy above. Below that, we did a small temporal craniectomy, evacuated the clot completely, and we could discharge the patient after restarting anticoagulants and antiplatelet drugs after 1 week. So chronic subdural hematomas and acute or chronic subdural hematomas, mostly seen in patients with antiplatelet drugs. Almost I can say nowadays very boldly I can say that every third patient with chronic subdural hematomas are on antiplatelet drugs. And invariably, unless we give them platelet transfusion, if you operate, the recurrence is becoming very, very common. So we have to give them antiplatelet drugs before taking the patient for surgery. With the history of recent trauma, it can vary on acute and chronic subdurals. So some can have a thick membranes and the subdural could be multiloculated. If the patient comes with a simple chronic subdural hematoma, wait for an adequate period, stop the antiplatelet drugs, and then you can safely operate. If the patient is deteriorated recently or come with an altered sensorium, then you have to do a platelet transfusion and you can do Burfols either under local or GA. But leave a subgaleal. This is what we have found has done a lot of changes in our outcome. Always leaving a subgaleal drain just across the two burrholes and wait for 48 hours until there is no drainage from the side. These patients, the recurrence rates have come down drastically. Also, acute and chronic multiloculated subdural hematomas, they require a craniotomy. Plan a craniotomy. Keep all the entire protocol has to be followed for reversal, and then surgery can be done by excising the membrane and following the same protocol. At times, what happens, these patients are so old and they are having so many comorbidities, you may have to do it under local anesthesia. A small mini craniotomy is done and the excision of the membranes has been done and the clot can be evacuated. If you have an endoscope with you in your hospital, this can be used to look for the corners somewhere where there is a hematoma. Those can be also be evacuated with an endoscope assist. Repeat scans before discharge and restart platelet drugs after 1 week. So this is the example of a small mini craniotomy which we have done recently. The patient came with a multiloculated chronic subdural hematoma with, you can see the very thick membrane it was present and it was multiloculated. So and this patient was a poor risk for general anesthesia So we had to do it under local anesthesia. Just we gave a linear incision, did a mini craniotomy, excised the membranes and evacuated the clot. The brain became lax, and then we could discharge him after 1 week. So intraventricular bleeds. We prefer to do a CT angio in all patients. Recently also we have what happened, one patient was admitted with an intraventricular bleed, which was a small bleed we thought we'll manage conservatively, was admitted under neurologist. He said, okay, manage conservatively. But unfortunately the patient did not undergo contrast CT nor had an angiogram. After 1 month, she had a rebleed, which we got an angiogram done, had an AVM. So we cannot rule out any bleed. It's better to do an angiogram. Without angiogram, if you say safely everything is normal, it's difficult to say. If aneurysm or AVM is seen, treat it accordingly. If there's a small bleed with no hydrocephalus, no intervention. The large bleed filling all the ventricles and early hydrocephalus, external ventricular drainage is a treatment of choice. Till the fluid is clear, you have to keep the drain with adequate antibiotic prophylaxis and CSF cultures. Change it to Ommaya reservoir. Once the fluid is clear, you can always change it to Ommaya reservoirs after 3 to 4 days. Repeat a CT scan if the ventricular dilatation is still persisting or if the patient requires repeated aspirations from the Ommaya reservoir, and if the CSS will become clear, then you can convert into a ventricular peritoneal shunt. During this period, anticoagulation is required, and if the patient has put on low molecular weight heparin, and which can be stopped 1 day prior to shunt surgery. So, in spite of all this, patient has to be in a low molecular weight with heparin if he has to go for a shunt surgery at a later date. So, subarachnoid hemorrhage. In this, there is no doubt angiogram is a must. CT angio is preferred. However, mostly they would be normal in this patient. Why I said because these can have a minor trauma, which they would have totally forgotten. And when you examine the patient, there may not be any bleed on the scalp. But after the CT scan, everything is done. Then you start seeing the subgaleal ecchymosis, and then we feel, oh, unnecessarily we have done. But it is always better if the patient has a subarachnoid bleed. It could be traumatic subarachnoid bleed, but we have to do an angiogram to rule out an aneurysm. Mostly, these are managed conservatively with anti-edema measures and other protocols for subarachnoid hemorrhage. But if aneurysms are detected, surgery is a must or intervention depending on the feasibility and cost and individual choice. This is the example of a subarachnoid hemorrhage with an intraventricular bleed. This was what, as I said, we did an extraventricular drainage, converted into a Ommaya reservoir, and later we have to put in a shunt for this patient. So intracerebral hematomas. This is the most topic where we find it very, very difficult to operate, not to operate, size of the clot, shift, all these things come into play, whether it is traumatic, all traumatic ones we generally operate and evacuate, but if spontaneous and hypertensive, to operate or not to operate. But those who are on anticoagulants and antiplatelet drugs, definitely the hematoma is going to expand. So they definitely need to, they don't even give you a time. Even before thinking, you have to take the patient to surgery. So sometimes it happens like that. The patient relatives insist on surgery, you have to take them and do whatever is required, have to be done. The hypertensive could be either, it could be ganglionic, cerebellar, lobar, thalamic, intraventricular extension, brainstem, etc., etc. On anticoagulation and antiplatelet drugs, either of them or both of them, they can have a rapidly deteriorating sensorial. Hematoma expansion is very common within few hours. Needs emergency evacuation and decompressive craniotomy after adequate reversal. These patients are, by the time they come to the casualty itself, they'll be either on ventilator or they would have been intubated somewhere and sent to the hospital because this patient was treated earlier in the same hospital. So when they are on ventilator, we'll have some time to do the reversal, give all the FFPs and antiplatelet prophylaxis, whatever have to be given, it can be given. If you think the patient is going to have a low GCS post-op, or if it's going to be on a prolonged ventilation, it's better to do a tracheostomy in the same sitting to avoid another surgery and another reversal at the later date. So you plan and tell for consent for tracheostomy also in the same sitting. During the surgery, what we do? Decompress the craniotomy or evacuation clot or both, depending on the swelling at the time of surgery on the table. So intraventricular bleed, if it is there, you can do an EVD on the other side or on the same side. And another thing what we have noticed is if you use bipolar coagulation too much and aggressively suck out the clot, post-operatively these patients can have persistent neurological deficit which may not improve at all. If you don't use bipolar too much and just gently take out the clot by irrigation and sucking out the clot as it comes out. These patients definitely we have noticed have a better outcome than those who have not, we have done too much of setting. Entire clot need not be evacuated. Some people say you have to evacuate the entire clot. That's also not required. You can wait once the brain becomes lax and pulsating, you can stop the surgery and you can come back. Either replace the bone flap or do not replace the bone flap depending on your choice. At times, if the flow seal is available, it's a very good option because it contains thrombin that can achieve hemostasis better. Now, if it's not available, you can use Surgicel. In urgent situations, mini craniotomies and plaque erection, this is what we used to practice in EMHANS when we were students there. We used to do a mini craniotomy, evacuate the clot as a life-saving measure, and generally request good follow-up scans and look for recurrences. So this is one of the example of intracerebral bleed, which with the ventricular extension and with a large ventricular dilatation also. So this patient, we did a craniotomy and then later put him on an EVD and converted into a Mayer reservoir. So this is what evacuation of clot, even those craniotomy is small, the bone flap could not be replaced. So we removed the bone flap. So same another case, intraventricular extension, total evacuation of the clot has been done. So to conclude, anticoagulants and antiplatelet usage is becoming more and more common these days, and with their associated complications are also becoming very common. Management depends on individual patients. So despite whatever the studies give, guidelines say, each patient is different. Each patient can have different comorbidities. Each patient weight, so many things can be there in addition to whatever is being said in the studies. So such patient requires individually tailored management. Patient outcome is what matters. See, you say I operated the patient, gone back home is different. I operated the patient, died is different. So what matters to the relatives is he alive or dead? Is he able to do his daily activities or not? Unassisted or is bedridden? This is what matters to the relatives. So quality of life is what is most important to the relatives when the patient is, especially on an older age group, in the patient, whether he has to be assisted every day for his day-to-day activities. They sometimes say, why did you make the patient alive? You would have left him alone, he would have died. It would have been much more easy for us. There are times patient relatives have come and said, had you not intervened, we would have been much more happier than after we have intervened. So these things are very, very important in these cases. We have to be vigilant at all stages in the perioperative period for a successful outcome. So outcome depends on right from the time the patient has come to casualty till he discharged. To prevent a thrombotic event, you have to restart, stop the anticoagulation, restart. So whatever, at all stages, unless you are vigilant, and it's a team effort, it's not a single man show. You have to involve your cardiologist, you have to involve your intensivist, and also you have an anesthetist for the successful outcome of these patients. Thank you.
Thank you, Dr. Mohan.
Thank you, Dr. Mohan, for the excellent talk.
Thank you.
Thank you for making the most difficult daily practice cases of anticoagulation and anti-platelet drugs usage and reversal, taking the consent and up to management and up to discharge. Thank you a lot.
Thank you, sir.
Mohan, can I ask you some question?
Sure. Go ahead.
In the thrombotic workup, when you expect a acute thrombotic episode in a case, it can be include homocysteine levels also in that if you have time. Serum homocysteine levels.
It can be done. Yes, see, basically, the thrombotic events are routinely done by the neurologist and cardiologist. They generally look at, as a surgeon.
Here we have a case and we have some time, as you said. And one more thing is, in an emergency situation where we don't have time, given that there is no time to give any reversal agents, can the general hemostatic, the drugs that are used in general surgery or gynec, like ethamslate or
when we started our practice in about 30 years back, myself and Dr. Sridhar, we were made to operate on one of the patients on anticoagulant drugs without any of these things available. You literally cry on the table. The patient will bleed like anything. You cannot stop. Ultimately, we have to shove in big cotton balls into the brain and come out,
Yes.
because you just notice that blood will be just pouring out. None
Right,
of the
I have
other
done it.
of any use. Unless you reverse it, you take the patient, you literally lose the patient.
Hey, do you have any experience with this stanogenic acid and the ethamsylate and the drugs?
I'm not able to hear you, sir.
Like the hemostat that I used in the general surgery or gynecology.
This tranexamic acid and all
Yes.
these things, they don't much
Ethamsylate.
work in the patient on regular anticoagulants.
Yes.
They are little useful, but they're not of much use.
In
And
neurosurgery.
best is to give them FFPs only, because other things are also not available in most centers. PCCs are not available. Only FFPs
Yes,
are
that's what I'm
available.
asking. That they are not available here also.
Protein available in most centers.
And one more thing is EVD.
Yeah.
When a hyperdense solid clot in the ventricles with hyperdense clot in the scan,
Yeah.
does the EVD work really?
So
Will it drain?
sometimes they work, sometimes they don't work, to be very frank, but we have to do is what we have to irrigate it sometimes. And by just doing that, sometimes what we routinely do is, if the clot is on one ventricle, definitely put in the ventricle where there is no clot.
I
So
put EVD when I see
doing
some
that-
CSF signal around the clot.
Yeah,
If
because
it's a solid white clot,
by
I
doing
don't even
that,
put a EVD.
some CSF is coming, will be definitely be coming out. Don't put on the
Thank
clot, the tube in the clot. You try to place
That's what I'm saying.
tube in
That's
such
what
a
I'm
way
saying.
that there's some normal CSF.
Thank you, sir. Nice talk.
Thank
Nice
you.
comprehensive coverage of routine problem actually. Very useful discussion.
Thank you, sir.
Very good.
Any other questions?
No, sir. No, sir. Carry on, sir. Thank you, sir.
Thank you so much.
Thank you.
I don't have any questions.
Thank
From
you.
the members, from the audience, yes. Is there any question from the audience?
Any questions from the audience?
Mohan,
Yapan, sir.
what type of cases you come across mostly?
Sir, for us in our hospital, we do a lot of this valve replacement. So most of them we come with this intracerebral bleeds only on anticoagulants. Antiplatelet drugs routinely seen in all chronic subdural hematomas. Nowadays, 1 in 3 patients are getting chronic subduals on antiplatelet drugs in the older age groups.
Not many with heart stents.
Stents are very rarely you do see, sir.
No, stent people also use anticoagulants in a milder dose.
Antiplatelet drugs, but the
Mild doses.
As I said, routine patients who come with intracranial bleeds are with anticoagulants. Fewer in the antiplatelet drugs. That's what I mean to say.
We here see mostly ICH and SDH.
Yeah,
Commonly.
yes. Commonly ICS and SDH.
Yes, sir.
We frequently see intraventricular bleeds also, sir.
Yeah.
Apart
They
from
are there.
chronic SDH and acute and chronic SDH and ICH,
That's why
we
I said
frequently see intraventricular.
That's why I described in all planes. We had experience with all the
Including
planes.
SH.
Yes, all. It's one scan I showed, no, where there was subarachnoid bleed and intraventricular bleed, but there's no aneurysm.
Yeah, correct. Thank
Okay,
you.
nice talk, Mohan. Nice talk.
Thank you, sir.
Yes, sir. Maleswara garu.
Sir, can I
Go
unmute?
on.
Can I mute?
Yes, sir.
Okay.
This session is concluded, sir. We have a tea break for 20 minutes, and then this next session begins in Hall C, Common Hall.
Thank you.
Thank you, sir.
Thank you very much. Thank you, Dr. Maleswara garu.
How are you, Sekhar?
Sir, fine, sir. Fine, sir. Fine, sir. Sir, yes, you are in Khammam, sir?
Khammam as visiting professor only. Visiting.
Vimala ఉంది అక్కడ మా అమ్మాయి విమలా ఉంది.
విమలా అసోసియేట్ కూడా అయిపోయింది.
అదే తెలుసు తెలుసు. దేనిక సార్ నైస్ సార్. ఓకే సార్, విల్ బి టేకెన్ కాఫీ బ్రేక్.
ఈ 20 minutes ఈ హోమ్ మేకర్స్ కి టీ ఏం లేదా శేఖర్ గారు? అమ్మా ఎవరు వెంకట్రావు గారు వచ్చారంటే
క్లోజ్ చేసేలా మళ్ళీ సేమ్ ఆ జూమ్ మీటింగ్ లోకి వెళ్తారు. ఇవ్వమంటారా ఉండాలా? ఇది ఇవ్వండి.
వెంకట్రావు హ్యాంగింగ్ మొక్కలు వేసి వెంకట్రావు పైన పైన మొక్కలు వేసి మర్చిపోక హ్యాంగింగ్ మొక్కలు వెంకట్రావు. ఇది ఇది వేలాడుతున్నాయి కదా వాటికి కొట్టదేవా వాటికి వేసి వెంకట్రావు కొద్దిగా వాటికి వాటికి రైట్కి ఇలా తినిపిస్తే సరిపోద్ది వెంకట్రావు గొట్టంతో. ఇది గోడ దగ్గర మొక్కలకి వెంకట్రావు అదే అది వాటికి వాటి మొత్తం వేస్తావా? అంటే ఇలా కాలుతోనే తినిపిస్తే అయిపోతుంది. అలాగా నడుస్తున్నావు కదా అలా దాని కింద నీళ్ళు పోస్తే అక్కడ వీటి కూడా వేసి వెంకట్రావు వచ్చుకోతా. ఇక్కడ వీటి కూడా దీన్ని కూడా వేస్తా మొత్తం ఆ దగ్గర మర్చిపోకేమి మళ్ళీ రేపు రావు కదా.
which may be confused with automatic performance. Movements, the non-net sensorium, what I consider the most basic complex conditions. Now, this 50-year-old lady with severe waning pain of both legs, and retention, palpitation, suspicion, and melting of the both legs for the last 2 weeks. Examination features a picture of the both knee and ankle different. And you can see what the patient is having, look at the muscle, but if something like a continuous, will try to have it, the clean movement with the prop, they make it like a back
When